All right, so we're going to start on the second section of cardiology. These objectives done. Okay, so we're going to talk about antihypertensives. We're going to go through the classes of drugs that we use to get patients' blood pressures down, and then we'll talk about when we use which drugs and how we use them. The nice thing about this, because there's going to be 4 sections of cardio total, the next 2 are going to be on the next section of the class, the last section. Be aware that a lot of these drugs end up pulling double duty. So like I can use a diuretic not only for hypertension, but I can also use it for CHF. I can use a beta blocker for angina plus hypertension. So drug selection is going to be a huge component of these kind of test questions, like which drug is going to be best for these patients based on things like they have a heart attack, or they have diabetes, or they have kidney disease. Like these are kind of questions that are going to be important. So keep in mind which patients are going to most benefit from these drugs as we kind of go through them and talk about the different classes. Okay. All right. So first off, diuretics. Went to the bathroom, otherwise you're in trouble. Generally, you're going to find that these are going to be drugs that increase urine flow, and they primarily do this by increasing sodium and chloride excretion. So you guys remember when we talked about this in physio, where salt goes? Water follows, absolutely. So again, if you had a sustained imbalance here, where you have too much sodium chloride intake or loss, obviously that would be fatal, right? So you can't have too little or too much salt. Obviously, if you have too much, you're going to end up having volume overload. You can have pulmonary edema. This is where a lot of CHF patients run into problems where they have impaired cardiac output and they hold on to too much fluids because usually they have a high salt diet, things like that. If you have too little, obviously you'd end up having volume depletion, cardiovascular collapse. That's no good either. So the kidneys are going to be kind of fighting us, and that's one of the things you'll realize with these hypertensive meds is that anytime we try to monkey with the system, the body's going to try to fight back against us, right? Because it wants to keep the pressure at a certain set point. And we mentioned that, remember those baroreceptors? They're really important for monitoring blood pressure, right? So if, say, for instance, like the baroreceptors have too little stretch and say blood pressure is too low, what do we activate in response to that? The Renin-Angiotensin system. We have things like antidiuretic hormone that all get activated, aldosterone. All these things are going to be really important to help increase that blood pressure. Now, remember, with patients who are hypertensive for a long period of time, what happens to those baroreceptors? They reset, right? So they kind of think that, okay, well, this is just my life now. This is just our pressure, say 180 over 100. Like, this is just normal for us now. So anytime you try to lower that, that same response happens. So you're going to get some pushback. And so this is why a lot of times patients require multiple drugs that working on multiple mechanisms to really fight back that feedback response, okay? So anyway, so again, talking about diuretics. Here. So again, kidneys receive a ton of cardiac output, around a fifth of that, and a lot of oxygen supply here, even though they're relatively kind of wimpy as far as body weight goes. And these are really responsible for a lot of these kind of reflex responses, because the kidneys monitor a lot of blood flow. They monitor things like sodium output by those juxtaglomerular cells, right? That's how a lot of that renin-angiotensin system gets activated, and we call this diuretic braking, right? So if you have too much diuresis, your body's going to try to put a stop to that with things like antidiuretic hormone, with things like the angiotensin II, things like that, to try to pump the brakes on the system a little bit to try to prevent that volume loss to happen too significantly. This is where sympathetic nervous system is going to come into play here. That renin-angiotensin aldosterone system we've talked about. Again, decreased atrial natriuretic peptide, increased ADH, and then also you can see renal cell hypertrophy is another kind of mechanism that can come in response to this. So obviously we've talked about this pretty exhaustively. You guys, you covered this in Pathophys just recently, correct?
Yes.
Fantastic. So I don't have to go. Usually I had to go over all this in super big detail, but I know you guys know from physiology all the how well they work. So you guys remember where a lot of the reabsorption of filtered things like glucose and amino acids occurs? Right, so the proximal convoluted tubule is really responsible for having a lot of reabsorption of things like glucose, salt, amino acids. About 50% of all the absorption actually happens right there in that proximal tubule. We're going to have, it's important to know where the diuretics are actually working in different parts of the tubule, so that way we can have an idea of, if you needed to add on a second diuretic, which ones would make the most beneficial sense based on the mechanism, based on where they're actually working at. So kind of keep those sort of things in mind right now. Obviously, we're filtering a lot of plasma, we're filtering a lot of the blood several times throughout the day in order to make sure we can get rid of waste products, but we're holding on to all the stuff we really want to hold on to, right? And you remember, if you have a diabetic patient who has chronically high glucose level, what happens to that glucose as it kind of gets into the nephron? Well, eventually kind of oversaturates those transporters, and what happens to the glucose then? stays in the urine. You pee it right out. That's why you get that diuresis. It's that polyuria you have with diabetic patients, right? Because they have too much glucose in the blood and they're filtering out to the kidneys. Kidneys can't reabsorb all of that. So kind of think about these kind of pathophys kind of things as we go forward. Because again, diabetes is going to be super intrinsic to talking about hypertension because they usually exist one alongside the other in a lot of cases, and so that'll be really important. So anyway, we know the proximal tubule is really good for reabsorbing glucose, amino acids, a lot of organic solutes. There's a lot of transporters there that are responsible for things like uric acid reabsorption, excretion of certain drugs and other substances into the tubules. About 60 to 70%, just to filtrate itself gets reabsorbed here. What's that loop of Henle used for? So helping to remove a lot of water, and that concentrates, and again, this is where the countercurrent multiplier actually occurs here. So again, this is where you end up seeing that a lot of water gets removed from that descending loop of Henle, versus on the ascending loop is where you have a lot of salt being removed. And again, that helps with that concentration here. So remember, the deeper you go into the medulla of the kidney, the higher the concentration goes, right? And this is really important to make sure that we can dilute or concentrate our urine effectively, right? So again, what do you think? What type of diuretics do you think are going to work here in the loop of Henle? Ooh, loop diuretics, yeah, absolutely. So you guys are already ahead of the game to begin with. Plus those on the site. But again, that'll be really important for, again, our most potent diuretics tend to be our loop diuretics because the salt reabsorption is so prevalent here that we can have kind of the biggest effects on urine outflow by blocking that. So we'll talk about that in just a few seconds. Obviously, the distal tubule. This is where our thiazide diuretics are going to be working, and also a little bit of aldosterone effects are happening here, especially in the kind of the distal portions of the convoluted tubule here. So this will be important for sites of action for things that block aldosterone, also things that block some of these sodium chloride transporters, and we see the thiazide diuretics mechanism. So again, they'd be working basically right here in the distal tubule. And then the collecting duct, again, not a ton of sodium being reabsorbed here, but could be another site where we can actually affect this. So things like ADH are controlling water reabsorption. Aldosterone is going to be really important here. You guys remember with aldosterone, what are we exchanging for sodium? Or aldosterone will cause more sodium to be retained, cause more water to be retained, but what gets spit out instead? Potassium, yeah. So that's really important as well because when we're looking at these diuretics that affect aldosterone, we also call them. So if I block aldosterone effects, my potassium would not be getting spit out into the renal tubule, so I'd hold on to them. I'd be sparing it, potassium-sparing diuretics. So this is where we're going to see those start to pop up. So we'll have specifically aldosterone antagonists and also potassium-sparing diuretics. That would be another important thing we'll look at here. Okay, so loop diuretics. These are going to be the most potent agents that we have here as far as diuretics go. You'll have them blocking, and I'll show you a picture of this in a second, with the sodium chloride potassium carrier on the ascending loop of Henle, right? This kind of blocks the effects of that countercurrent multiplier and helps us to keep more sodium within the renal tubule, and then that causes water to stay along with it, and so you end up diuresing it out, right? There's a few agents in this group. We have things like furosemide, bumetanide, torsemide, and then also this last one called ethacronic acid. Basically, the only difference between these is going to be the potency and how well they're able to cause diuresis, and that will affect the dose that you can see. So has anyone, especially from the EMS side, ever given Lasix before, or furosemide? What kind of dose do you ever give? Usually think like 40 milligrams, 80 milligrams of Lasix, something like that. Usually you can get away with much smaller doses because these agents tend to be much more potent. So say like, 5 milligrams of torsemide or something like that. But all in all, they're going to work pretty much equal effectively. Just depends on the dose you're going to give here. Does anyone know where the name Lasix comes from? It's not the eye surgery. It lasts about 6 hours. Yeah, absolutely. So first might last about 6 hours, so it gets the name Lasix. So a little bit of pharmacy trivia. If you ever go out to trivia night, might be a question. If it is, let me know where that's at, because that's where I need to be participating. So if you imagine kind of the luminal side, this is where this would be the thick ascending loop of Henle. This is where we have a lot of the sodium reabsorption occurring here. Here's the interstitium, kind of those paracapillary tubes, paratubular capillaries we're going to have here that are going to be reabsorbing a lot of this. Remember that sodium-potassium pump is super, super important for kidney function. This is why the kidneys require so much oxygen, so much energy, because they have this pump working kind of all the time throughout the entire tubule. So if I block this channel right here, if I'm preventing sodium, potassium, and two of these chlorides from entering into the cell, basically less sodium is going to be flowing across. We're going to end up keeping more of it at here, right? So we're going to be having more of it stay within the lumen, and you're going to be able to diurese it out because water is going to flow along with that. So obviously, if you had to imagine what type of electrolyte disturbances you could see with a loop diuretic, what could you see just right off the bat? Sodium. So you may see hyponatremia. You may see hypokalemia, right? Because more potassium is being left out here, so you're going to diurese that out. You can also end up seeing issues with things like magnesium, calcium, even potentially, right? So you have to be really careful with these diuretics because it can cause pretty significant electrolyte disturbances. Again, this can be problematic if you had a patient who had a history of, say, arrhythmia. Because again, we know if we monkey with the electrolytes outside of the heart, that can really cause potential for arrhythmia to occur. We'll talk more about that in the antiarrhythmic section, but just be aware of the fact that anytime you're changing electrolyte concentrations, you got to be careful with those heart patients, right? So when you block this, more sodium out here in the lumen, more of it's going to be diuresed out. So major action here, you can end up increasing urine output by up to 4 liters per day. It's a very significant means of getting rid of fluids, especially if you have fluid excess due to things like CHF, or if you had, say, pretty significant liver dysfunction, getting, what do you call it, like liver patients, getting these really big fluid-filled bellies. Ascites, yeah, so if you develop ascites is another decent way to get rid of some of those fluids. You'll see increased potassium excretion and excretion of calcium and magnesium. So basically a ton of electrolytes get affected by this. That can lead you more at risk for developing electrolyte abnormalities that we may have to replace later on. So some other actions you can see here. Now, again, a lot of side effects from these diuretics tend to be due to these kind of reflex responses that you'll see in the renin-angiotensin system and in the sympathetic nervous system. So potentially you can see hyperglycemia develop from this. And this is basically due to the fact that, one, hypokalemia can impair insulin release. So less insulin, less of it being shuttled into the cells, hyperglycemia, and then also that reflex catecholamine release. So things like beta-2 activation and alpha-2 activation can also decrease insulin release and increase glycolysis or glycogenolysis in the liver and start to produce more blood sugar. And so again, you can see that reflexive thing. And again, hypertensive patients may also be what? Diabetic, right? So again, you're already seeing some effects here where we can see that these can blunt the effects of your anti-diabetic medications. Good. And you also see the systemic vasodilator actions here. So you can actually end up having basically stimulating some prostaglandin synthesis here. Again, if you're seeing that, if you're thinking about the afferent and the efferent arteriole, remember what was responsible for kind of dilating that afferent arteriole heading into the glomerulus? Prostaglandin is really important for that. That's why we saw the NSAIDs can affect kidney flow, right? What was responsible for constricting the efferent arteriole? Angiotensin II, right? So angiotensin II is the other big thing we'll talk about when we get to the renin-angiotensin inhibitors. Basically, angiotensin II is responsible for constricting that. So again, if you can imagine the kidneys are getting affected by, they're losing too much fluid and you're getting hypotensive, the kidney is going to respond by doing things like decreasing prostaglandin synthesis to decrease flow into the glomerulus. You're going to have that sympathetic nervous system also vasoconstricting as well. So you're going to try to limit that kidney blood flow to try to maintain blood volume to, the heart and the head as being the primary places it wants to maintain blood flow too. So just be aware of that. You end up seeing some direct kind of relaxing effects on the muscle. We don't really know why this happens, and clinically this isn't super important. But just be aware that hyperglycemia is going to be one of the primary side effects you can see, especially in your diabetic patients. You end up seeing increased activation of the renin-angiotensin system, so it's going to be more angiotensin II is going to be formed here. Aldosterone is going to be in higher concentrations, and then more antidiuretic hormone. So this is your body's means of fighting back against the loop diuretics. And again, because loops are so potent, this is going to lead to the most potent response in this, trying to fight these effects here. So the other thing you're going to see is you're going to see decreased excretion of uric acid. I think you guys probably just talked about this yesterday, right? And with gout and whatnot. Yeah, so with diuretics, you end up seeing increased plasma uric acid levels, which could predispose you to gout. Or if you have a history of gout, this could worsen that as well. Also, if you had to imagine if you're taking diuretics, blood volume is going to go down. That could also lead to what with uric acid? So more concentrated, which could lead it to? Yeah, it would crystallize out or precipitate out, and so again, that could lead you to more risk for having a gouty attack, essentially. Again, this is mainly due to proximal convoluted tubular reabsorption. They're kind of fighting for the same transporter, so that's one means of doing that. Decreased tubular excretion and basically just that plasma volume contraction will also lead to being more concentrated and higher levels. You can see some, due to volume depletion, you can get kind of this mild metabolic alkalosis because you saw that we were blocking reabsorption of potassium, sodium, and then what was the other component there in that channel? Chloride, right? You want to keep chloride in the same, you want to keep the equation same there. So if you're losing a lot of chloride, that's the primary component of keeping the blood pH normal. You're going to have an excessive bicarbonate that can lead you to kind of a mild alkalosis there. And so also you can see some due to the sympathetic effect, you can have mild hyperlipidemia occur due to this, so increased triglycerides and whatnot. Again, that is something, you know, your patients may have hyperlipidemia in addition to their hypertension. So again, a lot of these disease states go hand in hand. And then also, you know, you can see blocking this transporter here in the macula densa. So again, that can affect things that are affecting, you know, the juxtaglomerarular cells that will affect things like, you know, angiotensin II release and GFR and all of that. Not GRF, I don't know what that is, but GFR should be the correct thing there. And just be aware that typically you're going to find that loop diuretics for patients who have poor kidney blood flow, poor GFR, creatinine clearance, like this is not going to be super effective for them. So typically, you will lose effectiveness of these loop diuretics as their creatinine clearance is lower and lower, right? You can still use it occasionally. You may get some effect from it, but you know, especially some patients, they become anuric, meaning they're not producing any urine. You're not really going to get much effect out of these loop diuretics, right? So we'll have other means of getting rid of fluid, things like dialysis and whatnot. But you know, lower the creatinine clearance, the less effective these drugs are going to be. Which makes sense because, you know, if you have less, urine being produced, less of it's actually getting that loop of Henle, it's not going to be as effective. Yes.
Sorry, just to clarify, so they're not effective if they have a creatinine clearance below 30?
They become less effective. Yeah, you can still use them, they just may not get as much bang for your buck as you would normally see. Yeah. Okay, so we typically don't like to use these for strict treatment of hypertension. We don't like to use diuretics only as a sole treatment for hypertension, mainly because of those reflex effects, right? Typically your body's going to respond to having that diuretic effect through the renin-angiotensin system, through ADH, through aldosterone, and basically blunt the effect. So you get a mild drop in blood pressure, but it's not sustained. Your body would just kind of adapt to it, would increase blood volume, things like that to level it out. So these are not good antihypertensives. Okay, these are good though if you want to get rid of fluid in the kind of short term. So they have pulmonary edema. This helps to get rid of that extra fluid and help reduce that pulmonary pressure. They have nephrotic syndrome. When you have nephrotic syndrome, you're losing a lot of proteins, and this makes it so it's very difficult to regulate plasma fluids because remember, plasma proteins generate that oncotic pressure that helps keep fluid in the blood vessels. So you kind of lose that. So it can be very useful if you need to get rid of that extra fluid. If we mention ascites, you know, especially if you have cirrhosis of the liver, hypercalcemia, you can actually use this along with saline to try to help flush that out through the kidneys because again, it blocks calcium reabsorption. So that's another good thing there. Heart failure. Usually they end up having edema, especially with acute exacerbations. If they have renal insufficiency, this is one of those things where patients have renal insufficiency or injury. Just because you're increasing blood flow or increasing diuresis doesn't mean you're necessarily fixing the problem, right? Because again, you can have the kidneys producing urine, but does not mean they're very effective at filtering or reabsorbing things like that. So you have to be careful with that. You can't just look at them and be like, well, they're producing urine, they're good to go. That's not really the whole story there, as you'll learn as you get more into nephro. And then occasionally for kind of short-term hypertension, if it's all really related to fluids, you may be able to get away with this, but again, not going to be effective for long-term management. Mentioned adverse effects due to that volume depletion. You're going to end up having reflex mechanisms we've already kind of alluded to. Hypokalemia can lead to things like cardiac arrhythmias. Hyperglycemia can lead to more kind of diabetic kind of effects there. Blood glucose is going to rise. You mentioned alkalosis. Gout could be more likely to occur. This is kind of interesting here. Ototoxicity can be another thing. So if you had a patient who had, say, very high doses of furosemide, something like that on board, that can actually lead to damage to the hair cells, very similar to what you might see with something like a gentamicin or a vancomycin. So again, these patients who are in the ICU who are super sick, they may end up being on multiples of these drugs that can all cause ototoxicity. You can see how they can kind of add insult to injury in a lot of cases. Okay. Hyponatremia can lead to seizures, allergic reactions, very rarely. Things like furosemide tend to be sulfa based, and so this is where we actually use ethacrynic acid as an alternative. So if someone had like a allergy to furosemide, we can use ethacrynic acid as an alternative agent to that. So that's kind of one caveat with that drug. And then if they're azotemic, they can actually increase their BUN. You're trying to hold on to more of that fluid. So that can be another potential adverse effect. So again, most of these make sense if you know the mechanism, you know the kind of reflex effects that the body's going to have to try to counteract that, right? Okay. As far as drug interactions go, this is again going to be primarily looking at either potentiating adverse effects of other drugs or kind of blunting the effects of some of these other medications. So again, with NSAIDs, if I were to have an NSAID come along and block production of prostaglandins, what's that going to do to the afferent arteriole? It's going to constrict, which means renal blood flow is going to decrease. We'll have less blood being filtered, which means my diuretics are not going to work as well, right? So that can be one of those things where it decreases the effects there. Mentioned aminoglycosides having ototoxicity. And then the other big thing is to really note for here are things like lithium. Like lithium we use for bipolar disorder. This is one of the things where you can actually have decreasing clearance and lead to potential for toxicity. So again, lithium looks a lot like sodium to the body, and so if you end up losing a lot of sodium, the body's trying to hold on to it, right, by doing things like aldosterone and things like that. So it ends up holding on to lithium too. So I've seen a lot of patients who get put on a diuretic. They were on lithium before, and all of a sudden their levels skyrocket, and they get really really sick, and they develop seizures and things like that. And then you mentioned the digoxin or digitalis, kind of two names for the same thing. We'll talk more about that in the antiarrhythmic section, but just know that causing electrolyte disturbances can predispose you to arrhythmias. So again, lots of drug interactions. Be careful when you're kind of combining these drugs. Make sure you run those interaction checkers to be aware of that. Okay. Moving on, next we have our thiazide diuretics. So again, I just put a couple here for use. We have things like chlorothiazide, otherwise diuryl is another name for that. And you have hydrochlorothiazide. Anyone know what you shorten that up to? HCTZ. So most people have heard of HCTZ. I had one patient came up and asked for their Huctaz, and it took me like 10 minutes to figure out what the heck they're talking about. But yeah, HCTZ is another common name you'll end up seeing for that, probably the more common one. We also have thiazide-like diuretics. These, again, you can kind of put them in the same classification as the thiazides. They work very, very similarly. We have things like chlorthalidone, metolazone, and then indapamide. This one I don't see used very, very frequently, but metolazone is kind of a unique one because, again, thiazide diuretics tend to not be very effective as your creatinine clearance drops. So again, less than 30 is not going to be super useful. But metolazone actually retains activity for whatever reason. So I one time heard a nephrologist talk about metolazone can get a rock to pee just so effective because, again, rocks have pretty poor creatinine clearance. I don't know if you guys knew that, but metolazone could still be effective. So that's kind of its claim to fame there. Poor kidney function, really bad creatinine clearance, metolazone gets to still be used. So these are going to be working in the distal convoluted tubule. So these are going to be working after the loop of Henle in the distal convoluted tubule. They're going to be blocking the sodium chloride transporter here. Okay. We'll talk about carbonic anhydrase activity. Clinically, we don't really care about this for the thiazides. We'll also see it has a little bit of activity at phosphodiesterase. But again, clinically, this is the big one we're going to focus on for this our purposes. So if you're looking at the distal convoluted tubule, again, this is the luminal side where the urine's at. This is the interstitium or the blood side. There's a transporter here. You notice that there's not going to be potassium being transported here. You still end up losing some potassium, mainly due to the effect that if you were to have a bunch of sodium in the lumen due to effects on the distal convoluted tubule, how does the collecting duct respond to that? Yeah, so it wants to hold on to more sodium, so it's going to end up spitting out more potassium. So you can kind of see, even though this doesn't directly affect potassium, you can still end up losing potassium in the long run, right? So you can always think about these kind of downstream effects. If you affect one side of it, what's it going to do downstream of that to try to affect it? So in terms of potency, you don't see nearly as potent of a diuretic effect with thiazides as you do with the loop diuretics, but they're still pretty good for the most part. And these are actually going to be one of our mainstay drugs that we're going to use for hypertension. We'll talk about why that is a little bit later. Also, a big thing to note here is that you end up having essentially calcium being reuptaken here. So this is one of the things where you may see patients who have a history of kidney stones. They will actually end up using a diuretic, usually a thiazide diuretic like this, because it actually helps to increase the amount of reuptake of calcium. Right, so less calcium in the renal tubule, less likely it is to crystallize out, and you don't have the kidney stones. So that can be another kind of nice use for thiazides. Okay. So again, these are going to work to block that sodium chloride reabsorption. So you're going to have probably inhibits maybe up to like 5% sodium chloride being blocked from being filtered, and it's going to increase urine output maybe 1 to 2 liters a day, not like 4 liters, not nearly as potent as a loop diuretic, but still pretty good. You'll see some increased release of potassium and magnesium through the urine. So again, you can still see electrolyte disturbances along with this. But the nice thing here, especially for those patients with nephrolithiasis, you can end up causing increased reabsorption of calcium. And so, of course, they already have hypercalcemia. That may not be a good thing for them. So again, all these decisions you're making kind of based on what the patient's electrolytes already are, kind of what their other disease states are going to be. So again, a lot of similar side effects as loop diuretics due to those kind of same reflex mechanisms. So the hyperglycemia, the uric acid increases, and again, decrease in GFRs are going to be kind of more related to hypovolemia more than anything else. But just be aware, again, these are all very similar to the loop diuretic effects. We will use thiazide diuretics mainly for hypertension. It's probably one of the main places that it gets used for. Again, you're thinking, well, like, why can't we use loop diuretics? Because you end up seeing those reflex mechanisms. Why doesn't the same thing happen to thiazides? I'll talk about why that is in just a second. Again, I want to keep you guys on the edge of your seats. I can tell you guys are on the edge. Okay, anyway, probably edge of something, right out your seats. But and if you need to get rid of fluid, this is where thiazides can come into play. So you have cirrhosis, you have heart failure, these can also be very useful. In some cases, you may actually see that you may use a loop diuretic and a thiazide at the same time. We call the patients who are getting high-dose loop diuretic therapy, they can develop what we call loop resistance. And it kind of makes sense when you think about it, because if the loop of Henle is not working effectively due to loop diuretics, the distal convoluted tubule can pick up the slack, right? So it can say, well, you know, we have all the sodium here, let's go ahead and start to transport more sodium in, and you see kind of a blunting of effect of the loop diuretics. You give a thiazide along with that, now you block that effect as well, now you get a whole bunch of diuresis. So if you ever see someone on a thiazide and a loop, that's usually what it's for, is to block that effect. My mom actually had that problem. She has a whole host of medical issues, but she had a lot of pitting edema, had a lot of fluid on her legs, and she was on, you know, Lasix. Several, you know, she would take that every time she had an issue, or it would pop up again, and eventually the loop diuretics just weren't working for her. Doc added on metolazone, actually ended up causing a huge amount of diuresis, and her legs were fine again. So if you ever see that, that's usually what it's for. Okay, so the reason why we can use thiazides for hypertension is, and again, this is going to work best in elderly patients, obese patients, and typically African Americans. So again, if you look at the guidelines, you'll see like, are you dealing with a Caucasian patient or African American? Because the pathogenesis of their hypertension tends to differ a little bit, and so they tend to be more likely sodium retentive patients. Okay, so they're holding on to more sodium, and basically, you know, if your blood vessels are chronically holding on to sodium and kind of the endothelial cells, water is going to flow into that. So we call this kind of water logging, where water is kind of being stuck in these the vascular in the vessels, and you've seen kind of this constriction that occurs because of that. By giving a thiazide diuretic, you can decrease that waterlogging effect that occurs there and get rid of a lot of that extra salt, get rid of that fluid, and it helps with the hypertension pretty significantly. You end up seeing pretty sustained effects with this, which is beneficial for a lot of your patients. So, you know, short-term decreases in volume output, short-term increases in decreasing cardiac output due to the blood volume, but you're going to see chronically, you're going to have decreased wall thickness, increased diameter, and you're going to see decreased response to things like vasopressors, which is again beneficial for your hypertension. So again, this is why we can use thiazides for this. For hypertension, loop diuretics not going to get that same effect, unfortunately. Why that is, I can't really tell you. That's just what we see in the studies. So if you were to look at this on a graph, again, if you're looking at blood pressure, systolic, diastolic, this is plasma volume, this is total peripheral resistance and cardiac output. You can see that initially when you start a thiazide, you have drops in your blood pressure. You're going to notice a drop in plasma volume due to the diuretic effect, and then total peripheral resistance is going to go down initially. Cardiac output is going to go down initially, but your body's going to want to respond to that by holding on to more plasma volume. So you can see here how it's going to try to kind of come back up due to the reflex mechanisms. But you'll notice that total peripheral resistance stays down. Cardiac output is going to kind of respond to that to try to maintain balance there, but you get a sustained drop in your blood pressure. So this is why we use these. And this, again, if you have like an African American patient, this might be one of the first drugs you go with for them for their hypertension. Again, we'll talk about the guidelines probably next time because we are out of time. Any questions I can answer for you guys? Okay, go use the bathroom. I'm sure everyone's been thinking about it. Okay, all right, we'll see you guys next time. We'll go on from there. All right, so continuing our talk of antihypertensives, this is going to be fast and furious because I don't know if you saw how many slides we have left to go through. It's a few. Any questions from the first section or last time we talked? All right, fantastic. So some of these things are going to be kind of like review from like drug class to drug class. So, and there will be a few things where I'm going to be like, don't really worry about it for the test. Normally I wouldn't do that, but because we were short on time, I'm just going to say, don't worry about it so much. Anyway, we're talking about thiazide diuretics. We said these are good antihypertensives. You don't really see that same loss of antihypertensive effects like you would like a loop diuretic, even though you will see some of these similar reflex mechanisms that we saw before. So again, similar side effects to the loop diuretics. It's usually not quite as severe. You don't see as big a fluid depletion. You don't really see as big an effect on the potassium. You will see some hyperuricemia, things like that. So again, pretty similar effects, but just not nearly as potent as your loops. Again, hypercalcemia, someone had a question like, well, why would you use this for hypercalcemia if it causes hypercalcemia? That goes back to kidney stones or nephrolithiasis, right? So if you have a person who happens to be prone to kidney stones, which again is basically calcium oxalate crystals generally precipitating out in the renal tubule, if I can get that calcium out of the renal tubule, they're less likely to have, the concentrations lower and less likely to precipitate. I can use a thiazide diuretic that will help that process to help us to reabsorb more calcium and thereby even though systemically the calcium might go up a little bit, you're not going to have as much calcium out there in the renal tubule. Does that kind of make sense? That's kind of where that comes from. So you might see some patients who are on a thiazide who are at high risk for that. Again, being in Florida, we have a lot of calcium in our water, so that could be another big thing, another risk factor you see for those patients. And again, as far as hyperlipidemia, again, a lot of that goes back to the sympathetic nervous system response, kind of the reflex response you're going to see there. And usually if you see things like dizziness, headaches, weakness, that's usually related to hypovolemia. So maybe if they did not, have a good fluid intake and they're on a diuretic, it's pretty more likely to see those kind of ultramental status changes. All right, with most of our antihypertensives, you're going to see some risk for sexual dysfunction. Again, anytime you're causing any degree of vasodilation or relaxation of the systemic vascular smooth muscle, you run the risk of having some degree of sexual dysfunction. It's usually pretty low for a lot of these drugs. Namely, like your loop diuretics. We'll talk about some other ones that are going to have more pronounced effects in these cases. You can see some constipation, and as I mentioned, while loop diuretics typically do retain a lot of their activity if they have a patient with poor kidney function, so like under 30 mLs per minute, thiazides end up losing a lot of function, right? There's one exception to that, which is going to be metolazone. This one does retain function under 30 mLs a minute, and so a lot of times we'll use this for patients who are like oliguric or anuric. If they're trying to put them on a loop diuretic, we'll also add on metolazone in a lot of cases to try to get the urine output up. Okay, so we mentioned obviously drug side effects are going to be with things like NSAIDs. It can be affecting the antihypertensive effect here, and then obviously anything monkeying with the electrolytes. Antiarrhythmics are going to be really prone to these kind of interactions. And again, we really prefer thiazides as kind of one of our go-to antihypertensives. We'll talk about which patients are going to benefit most from this a little bit later on when we talk about the guidelines towards the end of this section here. But again, few adverse effects. Most people tolerate it pretty well. Not a lot of issues with this one. Okay. So again, just to give you an idea, this slide kind of goes back to what we were talking about previously, those reflex mechanisms. I'm not going to belabor this too much, but obviously you can see with diuretic therapy, you're having this volume contraction that will have an effect on cardiac output. And is this going to be a permanent decrease in cardiac output? It's not, right? Because your body tries to respond to that by doing things like what? The RAS system, antidiuretic hormone, like it wants to hold on to more fluid. So again, you're going to see that cardiac output is going to be just temporarily affected there. But again, all this is going to come back to these reflex mechanisms will blunt the effects of these antihypertensives. Yet thiazides tend to stay relatively effective for a longer period of time, usually due to some kind of other, not necessarily due to the diuretic effects, but some of the other effects like on the blood vessels and that waterlogging that kind of gets rid of. Next up, we have our potassium-sparing diuretics. So as you might imagine, they're going to do what? Spare potassium, thank you very much. So again, there's going to be two kind of varieties here. There's going to be some that are going to be working as aldosterone antagonists, and there's going to be some that are working more specifically on blocking kind of that excretion of potassium into the renal tubules, because we mentioned that usually like kind of towards the collecting duct, kind of the distal into the convoluted tubule, and when you get to the collecting duct, that's mainly where you're going to see the sodium will be reuptaken at the cost of potassium. So a lot of these diuretics are going to be blocking secretion of potassium, so that way you're going to be having more sodium out in the renal tubule. More sodium means more water is going to follow it, and thus you get a diuretic effect. Now, if you had to imagine, say, how potent do you think these diuretics would be compared to a loop, more or less? Still less, right? Loops are always going to be your most potent ones. Thiazides less than that. Potassium-sparing diuretics usually less than that. This is why you oftentimes will see these added on to other antihypertensives or added on to other diuretics, because the effects are pretty minimal. But as we mentioned with thiazides and loops, what electrolyte are you losing that can be really important for like cardiac patients? Potassium. So if you mix it with one of these, it's actually going to get some kind of dual benefit there, where not only do you get some increased diuresis, but you also hold on to a little bit more of that potassium than you'd be losing otherwise. And that can be a good thing to try to keep their potassium levels kind of in check. So what we'll see here is that the two main ones we're going to talk about in just a second here are going to be working by blocking these luminal sodium channels, and so also kind of downstream to that inhibit that sodium calcium antiporter and also that sodium hydrogen ion antiporter, right? So less sodium making it into that cell, less of it's going to be able to be available to kind of get back into the interstitium. Thus, you're going to have more potassium being held onto in that case. Pretty minimal effect compared to like loops and thiazides, as I mentioned, but can have a moderate kind of increase in diuresis there. The two main drugs that come in this category include amiloride and triamterene. You rarely see these being used by themselves, and typically you'll add them in with hydrochlorothiazide. So it's a kind of a common combination drug. You might say like amiloride plus HCTZ or triamterene plus that. Similar indications as our other diuretics we've seen already, but again, much less of a natriuretic effect. When I say natriuretic, what does that mean? Pees out sodium, yeah, essentially. So it means so less natriuretic effect than you see with the loop diuretics, but again, still can be somewhat beneficial. Okay. Adverse effects, as you might imagine, if the patient already has a pre-existing chronic kidney disease and the potassium is already elevated, this can worsen that. So you do have to be careful, kind of a double-edged sword in a lot of those cases. And we'll see there's some other drugs that can also affect your potassium levels, namely your ACE inhibitors. We'll look at in just a little bit. But also they could be on potassium supplements. So if they're on that, you can see kind of a synergistic effect there. Okay, so be careful with that. Again, similar diabetic effects we saw before, some azotemia, but those are kind of the biggest things you're going to worry about. Kind of a rare one you might see is this anemia triamterene. I've never seen it, but relatively few number of patients are on triamterene in general compared to a lot of the other antihypertensives we'll talk about here. The other thing we can do in the collecting duct to help hold on to potassium and help with some of this natriuretic effect is going to be aldosterone antagonists. And so this kind of goes, when you say potassium-sparing diuretics, you kind of lump in these aldosterone antagonists kind of along with that because they have a very similar effect here, just a little bit different mechanism. But basically by having, aldosterone normally is going to be binding to the intracellular, into the nucleus, or those renal cells, and it will increase protein synthesis. We're going to have more of these sodium channels being put into the membrane, and we're going to have increased activity of that sodium-potassium pump, right? So by blocking that effect, you'd have less sodium channels, less sodium can be reabsorbed, thus more sodium stays out in the renal tubule. You can see here, these sodium channels will be affected by aldosterone, but if we can have a receptor here within the nucleus that will, drug coming in and block that, you'll have less of those sodium channels and more sodium stays out here. The main two drugs here we're going to look at are going to be spironolactone and then eplerenone. Have you guys seen spironolactone used previously? Yeah, for acne, right? So again, it's very similar because it blocks some of the aldosterone effects you can see kind of affecting the acne. But yeah, so spironolactone can be used occasionally. Spironolactone is not usually used for the aldosterone effects for acne, more so it is for the anti-androgen effects that it has. So we'll see that it's going to inform some of the side effects we're going to see with this medication. But again, spironolactone and then eplerenone are the two in this aldosterone antagonist category. So again, they're going to bind to that steroid receptor. They're going to have most effect when you're kind of in a high aldosterone kind of state, right? Because again, it's where aldosterone is kind of overactive. They can come in and block these effects. That's going to have the most benefit. So usually in a patient with kind of an overactive renin-angiotensin system, these drugs are going to work a little bit better for it to work. And so you're going to see again, not kind of pretty modest increase in sodium chloride excretion, but you're going to find that you hold on to more potassium. So again, similarly, these would be potassium sparing in that respect. So the primary places you're going to use this, you have a primary aldosteronism. That would make sense since these are going to block the effects of aldosterone for hypertension. And then this is interesting in that for patients with CHF or congestive heart failure, have you guys covered that yet with Dr. O? Not yet. Okay, so you guys will get to that. We'll talk about it in the next portion of the class. But basically, when you have a little bit more progressive disease, class 4 heart failure, those are usually more symptomatic patients. They actually find there's actually some mortality benefits by adding on an aldosterone antagonist. It's kind of one of the unique things where depending on the stage of disease they have, they may benefit from these drugs versus they were, say, relatively early on, they may not get that benefit. And then for some edematous conditions, you may see this being used to help get rid of some of that extra fluid, like in nephrotic syndrome or cirrhosis. So I mentioned adverse effects. Hyperkalemia is going to be one of the biggest issues you're going to see with this one. And then the weak androgenic effects, I should say, they're partial agonists, not really antagonists of the androgen receptors, but the partial agonists. And what that can mean is that for men, if you're getting only partial testosterone effects at a lot of those receptors, you can see things like gynecomastia form, testicular atrophy can occur here. That's usually, for a lot of your male patients, what kind of stops them from using the medication in a lot of cases. Gynecomastia can be pretty distressing to them. They don't want to take it anymore. You see this less with eplerenone. Typically spironolactone kind of gets the most blame for this one, but also eplerenone is a lot more expensive. So again, it's a kind of a cost-benefit analysis there. For females, you can see things like menstrual irregularities due to this kind of, because again, usually females are going to have less testosterone or androgen effect in the body. So now you may be increasing that a little bit. So you can see things like that menstrual irregularity or hirsutism. But again, eplerenone is going to have less effect here, which is going to be a benefit. Okay, and then the kind of the last class of diuretics we're going to see here is going to be our carbonic anhydrase inhibitors. You guys remember where we saw this last? Yes, the eyes have it. Yeah, so the eyeballs, we did this for glaucoma. We actually inhibited carbonic anhydrase. So remember dorzolamide or brenzolamide? Both of those drugs actually had the same mechanism. They're just applied in the eye for glaucoma. Basically what this is going to do is inhibit that carbonic anhydrase enzyme. You guys remember what that enzyme does? Take CO2 and water, puts them together to make bicarb, or it can split them apart to form CO2 and water, right? So based on that activity, you can kind of shuttle a bicarbonate or sequester it in certain areas, whereas if you keep it out in the renal tubule, it's just going to get peed out. So again, normally what you might see is a little bit of an acidosis that occurs with a lot of the other diuretics. This is one of those things, I'm sorry, you might see an alkalosis with the other ones. This is one of the few ones where you might actually see a small acidosis form here because you're actually peeing out more bicarbonate. This is going to work though in the proximal convoluted tubule. Okay, so again, we went from the loop of Henle for the loop diuretics. We saw the distal convoluted tubule for the thiazides, and then mostly collecting duct for potassium-sparing diuretics. Now we're going back to the proximal convoluted tubule, right? Now the reason why these are pretty wimpy as far as diuretics goes, because again, if you block this reabsorption of bicarbonate, you're kind of drawing more water with it. In the proximal convoluted tubule, you have all the rest of the nephron in order to reabsorb that water, right? So this is why you see kind of minimal effects here, but again, can be used occasionally as kind of an adjunct. So again, we're going to see more bicarbonate being excreted. I'll show you a table of this in just a second. But again, generally you're going to find that for chronic use, this is not a great diuretic. But we'll see there's also some other uses for it that we can use occasionally. The main one in here is going to be acetazolamide or Diamox. This is the most common one you're going to run into. It's also dichlorphenamide and the metholazomide, but I've never actually seen either two of these being used. But acetazolamide is the primary one you'll run into. So you can imagine here you have the lumen, here's the interstitial space on this side. Normally what you would have is a carbonic anhydrase would do things like breaking apart bicarbonate. Bicarbonate has a hard time getting across the membrane by itself because again usually it's going to dissociate from hydrogen, it's going to have a positive charge on it, so it doesn't like to get reabsorbed. However, CO2 and water tend to be much more readily reabsorbed. So by having carbonic anhydrase facilitate that, you're going to have more reabsorption of carbon dioxide and water, and again to the cell, and they can be reformed into bicarbonate, can have this kind of normal reabsorption at that point. By having a carbonic anhydrase inhibitor like acetazolamide on board, you're preventing this action from happening. This bicarb sticks out in the lumen and then just gets eliminated along with some extra water throughout the rest of the nephron. Make sense? Mainly, glaucoma is going to be the primary use. You're going to see a lot of these, but what's interesting, which you might see, is some other of these uses here. So again, epilepsy, which is what? A seizure disorder, right? So actually, in some cases, when you have a mild acidosis, you can actually raise the seizure threshold. It's always I have a hard time saying that, but you make it more difficult for them to actually seize. So sometimes you'll see patients on this, try to make them more acidotic, harder to seize. You can see this used for mountain sickness or like altitude sickness. Some people might be put on this, so they say, like, hey, for instance, some of your faculty are going to go into Denver, Colorado here in a couple of weeks. We might take this beforehand to try to prevent any kind of altitude sickness from happening there. A lot of that has to do with things like cerebral spinal fluid production and whatnot. This can also help with swelling that can occur within the brain after, say, like a traumatic injury or something. So just some ancillary uses you might see these being used occasionally. Again, not typically as an antihypertensive, but still technically a diuretic, so we'll mention it here. Okay, mentioned as far as adverse effects go, you can see a metabolic acidosis as opposed to usually a contraction alkalosis you get with a lot of the other diuretics. Some potassium depletion, maybe some drowsiness, but other than that, pretty well tolerated. I'm sorry, one more class of diuretics, I forgot. You also have the osmotic diuretics. And so these are going to be drugs that get filtered through the glomerulus, but they actually don't have any kind of reabsorption within the tubule. What it does, though, is by having a high osmolality within the renal tubule, it's going to draw a lot of water along with it. So again, this is more like basically just kind of flooding the lumen with a ton of osmoles, and draw a lot of water with it, and you just pee it right out. Okay. So the main ones you might see being used here include things like mannitol. This is probably a more common one. Again, very often these are not used as diuretics. You kind of use these for other purposes. You might just get an extra diuretic effect kind of as a side bonus here. But mannitol is probably the most common one we run into. Occasionally you might see urea, which kind of makes sense because your urine has some urea in it anyway. But these are going to be the most common ones. Probably the mannitol you run into. So typically, what you can see is people may try to use this during acute renal failure. It's not going to be all that too effective for it. But one of the big things we'll see mannitol being in urea to a lesser degree is for either cases of acute glaucoma, when you want to get a lot of that fluid off very quickly. Because again, mannitol you would give into the via IV, and that would draw fluid from all sorts of spaces because it's very hypertonic. So again, it would draw fluid from the CSF, it would draw fluid out of the eye, things like that. And so again, if you have cases of cerebral swelling, glaucoma, you can draw a lot of that fluid off and just pee it right out. And so again, if you're ever working like in a trauma center, like a surgical ICU, this is probably one of the primary places you'll use mannitol. Then we know an alternative you could use, like maybe an electrolyte, you could use at very high concentrations to do the same thing. Ever heard of anyone using hypertonic sodium chloride? So normally, like a normal saline, you remember what concentration that is? 0.9%, yeah. So we can use 3% sodium chloride, much more concentrated, a lot more osmoles in it. By giving a hypertonic solution, you can do a similar thing where you draw fluid off of the brain. So that's usually a more common thing we'll do in a lot of trauma centers, but you still can see mannitol being used occasionally. Does that kind of make sense? So again, having a very hypertonic solution, you're going to draw water from, another space, through like, say the blood-brain barrier, etc. And that's how you can pull that fluid off. Okay. So any question on diuretics? Does anyone ever seen mannitol at like relatively cold temperatures? A vial of it. It's kind of interesting. It likes to crystallize out. I have it in I think a later slide set somewhere. But you have to keep it warm. So every hospital you'll usually find they have a mannitol warmer, which is kind of like an easy bake oven. It has like a little light in it that'll keep it warm. Keep the drug in solution, because otherwise, if it's crystallized, you don't want to give that into a patient because it crystallizes in them. That's no good, right? So anyway, renin-angiotensin aldosterone system inhibitors. So we know a lot about the renin-angiotensin system already. I don't have to kind of belabor a lot of these points, mainly due to the fact that we covered it in physiology already, right? It's just review. Okay. Anywho, we know this is a major controller of blood pressure within the system, including things like secretion of aldosterone, renal blood flow, all sorts of issues here. And so we're going to look at ways we can monkey with the system essentially to try to help get our blood pressure down. We'll see some other kind of nice pleiotropic effects, if you guys remember that term, that it can have on the body. So again, kidneys, when they sense that they are getting kind of low sodium or low fluid volumes through those juxtaglomerular cells, they're going to be able to signal that, hey, we need some extra renin, we need some extra blood pressure here. So they'll release renin. Angiotensinogen, anyone know where that comes from? In the liver, right? So angiotensinogen is going to be released from here. That's going to convert this over. Renin's going to help the conversion over from angiotensinogen over to angiotensin 1. This is not the main clinical thing that we're really concerned about, but what we are starting to see here is now we have angiotensin converting enzyme, or ACE, is going to convert this over to angiotensin 2. And this is the primary thing that we're focused on here, where it has a lot of vasoconstrictive effects. You're going to see that this will cause positive effects in the adrenal cortex to release more aldosterone, and it's going to affect the arterioles to cause vasoconstriction. Both of these things are not good for hypertension, for things like left ventricular remodeling, for CHF, all these different conditions. We're going to see this is a bad thing. We typically want to help to limit these effects here. So also, angiotensin converting enzyme is also responsible for breaking down a product called bradykinin. Bradykinin is typically going to be vasodilatory, but also is going to be responsible for one of the primary side effects of an ACE inhibitor, which we'll see in just a little bit. So again, as we mentioned, that renin-angiotensin system is going to be controlled by things like the renal baroreceptors, which again, are sensing pressure, that macula densa, and then the sympathetic nervous system. More sympathetic effects, more renin-angiotensin activation. Bless you. So, we know this, the decreased renal perfusion is going to increase renal release. Makes pretty good sense. Again, I'm not going to belabor these points too. And obviously, the sympathetic nervous system is going to help with things like, innervating the juxtaglomerular cells. So increased activation is going to just get more renin being released there. Okay. So angiotensin 2, the primary component we're looking to focus on, at least most of our drugs are going to be focused on this, is going to cause vasoconstriction, stimulate aldosterone secretion, causing renal vasoconstriction. Because remember, is that working on the efferent or the afferent arteriole? It's going to be on the efferent arteriole, remember, the one heading out, because we want to cause pressure there. Again, imagine a patient has, say, poor renal blood flow. You want to increase the pressure at the glomerulus, so you're going to squeeze down on the efferent arteriole, kind of like putting a kink in the hose almost, to try to increase that filter pressure. And so that's where angiotensin 2 is going to have a big effect there. And again, it can also increase your sympathetic nervous system to increase outflow as well. So it's also going to cause norepinephrine release by acting on some of these presynaptic sympathetic nervous neurons. It can help to stimulate thirst and help with ADH secretion essentially, which again, ADH means we're going to absorb more water from those collecting ducts, right? And so you can also end up seeing, this is what really is going to be the important thing for the long-term use, is it can cause tissue or cell hypertrophy and cardiac remodeling after an MI. Right, so after an MI, when we've caused ischemia to the heart, like it needs to repair itself, and so this is a lot of this remodeling leads to like what changes happens to the ventricle. Yeah, after an MI, kind of what happens? Anyone know what happens to it? Yeah, so it gets stiffer, it gets more scar tissue to it, it becomes less pliable, and so these remodeling leads to things like impaired cardiac output or things like impaired filling volumes, and so this is what are some of the things that lead to congestive heart failure because your cardiac output is suffering because of these changes that are occurring. Angiotensin II is really important for this, and so this is why not only are these drugs going to be indicated after a heart attack, but this can also help to prevent a lot of these changes that occur that lead up to a heart attack, right? So we'll look at some reasons for that in a minute. Okay, so again, overactivity of the renin-angiotensin system we know can lead to hypertension, can worsen congestive heart failure. We can also see a diabetic nephropathy, right? So again, by constantly having high blood sugars and by constantly having these high pressures in the glomerulus, you see eventual damage occur over time. These are kind of the microvascular changes that occur in diabetics. So again, we're going to find that if you can affect the system, that is going to be nephroprotective for your diabetics. So again, another really good case where we're going to use these drugs. And then again, I mentioned that myocardial remodeling post-MI. And so we notice, at least in the large-scale studies we've done, we've seen that we have improvement in morbidity and mortality in patients who we can limit these effects of angiotensin II in their systems. Okay, so again, this is going to be a primary thing you're focused on when you have, say, a patient being discharged from the hospital after an MI. They're going to be on a certain list of drugs, and this is going to be included in that, some sort of drug to affect this system. So, looking at if we were to inhibit this enzyme, this angiotensin converting enzyme, if we prevent the activities of that enzyme, we can see decreased vasoconstriction. We're going to see decreased renal vasoconstriction, right? We're going to have decreased synthesis of aldosterone, less sodium reabsorption. Again, so you can see a little bit of a natriuretic effect there. You have decreased bradykinin metabolism, which is going to be responsible for some of the side effects we'll look at. And of course, you're going to end up having interruption of that negative feedback. Usually, if you have enough angiotensin II, if you have enough renin, that can lead to a negative feedback loop. You're actually going to be blocking this effect because, again, you're not going to have nearly as much angiotensin II activity as you did before. So again, you can see, even though you're interrupting that negative feedback, you really can't produce any more angiotensin II because all your enzymes being inhibited here. So as far as ACE inhibitors go, you're going to find they all have identical mechanisms of action. They're all going to inhibit this enzyme. You're going to find that the main differences include things like their metabolism, their half-life. A lot of them end up being prodrugs. Remember, guys, prodrugs are inactive normally, and they have to be changed over in the liver to be active. And so this is where it's not important to know these exceptions here necessarily. I just kind of mention it so you know that when you give the IV form, you don't get that first pass effect, right? So we actually have to give it in the already active form. I'll show you an example of that in just a second here. And again, most of these are going to be eliminated through the kidneys. So again, look out for kidney function. You may see some accumulation of drug with those. So these are the main drugs. There's actually 2 slides of these because this is actually a big, when the first ACE inhibitors were starting to come out, they were kind of a big deal, blockbuster kind of drugs. So this is where you saw a lot of Me Too drugs that are being coming out as well. And so it always seems like there's more and more of these. I think it's kind of slowed down for the most part, but there's a lot of ACE inhibitors out there. But what do you notice about the name? All into pril. So you always know your ACE inhibitors that always end with pril. So you have captopril, lisinopril, enalapril, benazepril, fosinapril, and then trandolepril. Right? These all get converted over if they're a prodrug to the trandolepril at. I would basically add an AT to the end of there. So if you ever see that with the enalapril, the actual IV form that we give is called enalaprilat or vasotag. So if you ever see that, that's actually the IV form that does not need to be activated. Because again, when you give stuff IV, you bypass the first pass effect essentially. But this is a good one to know just because enalaprilat is the go-to IV form. So if you had someone with, say, in the hospital or in the emergency department who has having acute hypertension, you can give an IV ACE inhibitor and actually have pretty quick effects to block the actions of angiotensin II and can lower their blood pressure pretty decently. We also have quinapril, ramipril, perindopril, moexapril, and then perindopril. I'm sorry to say, I put that one twice. Oh well, that one's not necessarily more important than the others. I was probably just very tired when I made that. So anyway, so again, just be aware. There's lots of them that are out there, but you can notice the name. You can already know what type of drug it's going to fall into, what category. Okay, most of them are going to require just daily dosing, which is again convenient for compliance's sake. You may see some of them being given twice daily, especially if you start to notice that their blood pressure is good kind of in the morning time after they take it, but then it starts to trail off a little bit towards the end of the day. Some people may require twice daily dosing, but for the most part, once a time is just fine. You're going to notice there's kind of an effective dose range that a lot of these drugs are going to have where you kind of hit a plateau effect eventually, where even if you keep increasing your dose, you don't get necessarily a whole lot of extra benefit, because again, once all that angiotensin converting enzyme is inhibited, you can't really do much else other than that, right? So again, this is where you can see that's when it may be a good time to add on a different class of drug, a different mechanism, in order to get some additional benefit here. So therapeutic uses, we're going to use this primarily for hypertension. This gets down our total peripheral resistance, helps to decrease both systolic and diastolic blood pressure because you have less angiotensin II causing vasoconstriction. This also is going to help with decreasing some of this left ventricular hypertrophy due to that elevated pressure, right? Because the pressure that the heart's having to beat against is called what? It's the afterload, right? So the higher the afterload, the harder the left ventricle has to work. And then what does muscle do when it gets overworked? Gets bigger, right? So the bigger the left ventricle gets, the stronger it gets, but it also is getting stiffer, not able to fill quite as well. So again, these are some of the problems that lead to eventual congestive heart failure. So this is the nice thing here, by decreasing that total peripheral resistance, you end up causing the left ventricle to not have to work so hard, which is good. And also we're going to see this be preferred in diabetics, mainly due to the kidney protective effects, right? So it can be one of those things where if like, hey, you have a diabetic patient, an ACE inhibitor is probably going to be pretty good for them, mainly due to those effects. And again, especially with like kidney dysfunction, can you reverse any of that damage that's been done? No, you can only stop it from getting any worse. And a lot of times, we have two kidneys. It takes a long time. You lose a lot of function before you really start to see your creatinine clearance drop. And so because of that, the earlier you can start these patients on it, the more kidney function you can preserve for a longer period of time. So again, starting early is usually a good idea. I mentioned the left ventricular dysfunction. This helps with that remodeling, the hypertrophy, causes that decrease in afterload, have a decrease in the preload, and thus cardiac output can then go up, which is going to be a good thing here. And then again, it's going to help to prevent or delay progression of CHF. So again, similar with the kidneys, can't change the left ventricle back unless you were to transplant a whole new one in there. So again, starting earlier is going to be a good thing for a lot of these patients. We've seen, even after MI, after they had damage done to the heart, you can actually decrease rehospitalizations afterwards if you start a patient on one of these ACE inhibitors. So again, good mortality effects on these patients. So again, as you might imagine, if you have someone who has heart failure, so again, their cardiac output has suffered because their left ventricle cannot it's not really up to snuff necessarily. I'm going to see this decreased cardiac output, which again leads less blood flow to the kidneys, which is going to do what to renin? Should increase it, right? So you have more Ang2, which could cause more aldosterone to be released, more vasoconstriction, all of which kind of goes back, feeds back to affecting the heart even worse. So you can see it's kind of this kind of cyclical effect here, where as the heart function gets worse, you release more renin. It's going to cause the heart function to get more terrible, and then it's just kind of a sick cycle. So if you can inhibit somewhere, namely by affecting angiotensin converting enzyme, you kind of put a stop to it and hopefully prevent any progression of disease, at least as much as you can. So we can also use these post-MI, as I mentioned, help with some of that remodeling, and then overall decreases in mortality after MI. So again, good thing for these patients to be on. Also mentioned diabetic nephropathy. This helps by decreasing glomerular pressure, and then a lot of the remodeling happens there as well. Again, well, just slow progression, hopefully stop it, but it's not going to reverse anything. Side effects. Okay, so a big side effect with ACE inhibitor. Anyone ever heard someone on an ACE inhibitor, their dry cough? It is maddening. It will cough just all the time, 24/7. It can be very distressful to the patient because, again, they have to live with that 24/7, so it can keep them from sleeping, cause insomnia, all kinds of problems. And so, 5 to 15% of patients are going to have this, and it's namely due to the bradykinin buildup. It's also another substance called substance P. It can have accumulation in the lungs, and again, all of it kind of sensitizes the respiratory tract to having that cough. Again, it's non-productive. It's just they have this just urge to cough constantly. And so this is going to be one of the main reasons why you would switch a patient off of these drugs over to something else. And we'll see what that something else is in just a little bit. Again, it has nothing to do with the dose or the specific agent. It's just some patients are going to be more predisposed to this than others. We typically see it a little bit more frequently in women. But if really bothersome, you can move them over to something else, which we'll see in just a second here. Because we were having decreased aldosterone secretion here, you're going to see that you're going to have rises in your potassium levels, right? So again, it's pretty consistent. The patient already has hyperkalemia to begin with. It's maybe one to avoid, right? Because again, you're going to cause that to raise up even more so. It may happen more likely in patients with renal disease where they're kind of holding on to more potassium to begin with, or if they're on a potassium-sparing diuretic or some other supplement with potassium in it. And then obviously with hypotension is a risk with any of these antihypertensives. Usually you're going to see this with a lot of patients, especially if they're a little bit more frail, a little less hemodynamic reserve. You can start them at a lower dose and then gently titrate them up, right? What's kind of a big sign of hypotension that you can see with some of these patients? Yeah, lightheadedness, dizziness, especially older patients, it might be more likely to. Syncope or have a fall or something like that. So again, a lot of these drugs you may want to dose around the evening time, so that way they can take it overnight, and that way they're not going to necessarily be at least awake for a lot of that dizziness and whatnot. They can get more used to it, and then they can take it during the daytime. So again, sometimes we will dose it around the evening just so they prevent some of those effects. One thing I would note, especially when we're talking about the diuretics, obviously giving people diuretics is going to cause them to do what? Get up, yeah, so they have to get up in the middle of the night and go pee. Again, think about that. It could be a cause for some of your really older, frail patients. They may be more likely to get up in the middle of the night. It's really dark. They don't see something. They fall, break a hip, and then, it's no good. So again, always kind of keep these little things in mind when you're, deciding your drug regimen for your patients. Okay, renal function impairment. So again, patients who already have pre-existing renal disease that are really dependent on that angiotensin II vasoconstriction to keep your GFR up, right, to keep that glomerular filtration pressure. If you give them a big dose of an ACE inhibitor, you're going to see less angiotensin II, that efferent arteriole is going to dilate, and guess what happens to their renal function? Drops, right? Because again, they left pressure, the blood flow is just going to go straight by it, nothing really gets filtered out of the glomerulus. So again, this is another case you want to start low and go slow. Patients with renal disease are not going to be contraindicated from receiving an ACE inhibitor because again, this is going to be protective on their kidneys. You just start at a low dose and see how they tolerate it and just go kind of titrate up as they tolerate it. Other kind of rare side effects you might see with these, angioedema, which again, somewhat related to anaphylaxis, but isn't like a true anaphylaxis reaction. It's not really treated the same way. You can see rapid swelling in the nose, the throat, the mouth. This can be very, very dangerous, especially because the big thing that's going to kill these patients with angioedema is airway obstruction. Absolutely. So I remember seeing one guy in the ER. He had a previous history. He knew he had angioedema to an ACE inhibitor, but it had been a few years, and he really wanted to get his blood pressure under control. He really promised it to his grandma or somebody, and he said, "I want to get my blood pressure under control. Let me just go ahead and start taking it again." Sure enough, angioedema comes right back, and where he's in the ER, and his just tongue is like sticking totally out of his mouth. Everything is completely swollen, and it's very difficult from an airway perspective because everything's swollen. You can't really get a laryngoscope in there to really intubate the patient. We end up having to use fiber optic scope going down the nose in order to make sure we can actually get an airway. So it's a very, very difficult patient, but just be careful with that. Again, this is not something you want to re-challenge a patient with that they have a previous history of it. And the other thing is that it's not super predictable on who's going to get this. This is one of those things where, like, an allergic reaction, you think about it, you get challenged once, you may not have an effect. You get challenged the second time, you're sensitized, and there you go. This one, it can happen, roughly a third of the people will occur within the first dose, or, say several weeks of dosing. The other third of people who get this will happen maybe within the first year of dosing. And then there's another third of people who can take angiotensin converting enzyme inhibitors for years, never have a problem, and all of a sudden they just develop it, right? There's no real rhyme or reason to it that we can figure out, but just be aware this can happen even if they've been on it for years. The other thing you want to be careful of is going to be this fetal morbidity and mortality. These are going to be contraindicated during pregnancy. Again, ACE inhibitors, we'll talk about it when we get to kind of like women's health section. I think in Pharm 2, we'll talk about antihypertensives, but ACE inhibitors, anything affecting the Renin-Angiotensin system, we do not want to mess with in pregnancy. These are going to be contraindicated. This should actually probably be unindented. I should kind of move this over. But NSAIDs can affect ACE inhibitors, can actually make them work less effectively. Again, very similar. NSAIDs always end up blunting the effects of your antihypertensives due to that prostaglandin activity in the kidneys. So always be careful with that one. Okay. So if you couldn't get an angiotensin converting enzyme inhibitor, what other way could we affect angiotensin II? Block the receptor, right? So that's where we have angiotensin receptor blockers, right? So ARBs. So again, you can see that there could be other pathways for angiotensin II production. There are other enzymes that can do this, but what we can focus on are actually the receptors themselves. And so there's an AT1 and AT2 receptor. We're not going to focus necessarily so much on the differences here, but the main one we're going to see having effects are going to be the AT1 receptors. We find this on the endothelium, we find this on the heart and the kidney. This is the primary thing here. This is the endothelium vascular smooth muscle, so that VSM stands for. So this is the primary thing that our drugs are going to come in, block, and it doesn't matter how much angiotensin II you have, it's going to have a hard time interacting with those receptors. So these bind pretty well to that. So as you might imagine, again, looking at the same picture we saw previously, angiotensin II, if it affects the AT1 receptors, this is where the vasoconstriction, sodium reabsorption, all of this is what we're really concerned with. This is going to be more seen, AT2 is going to be more seen with like fetal development, so not really germane to our purposes here today. All right. So again, very similar actions. You're going to find that therapeutically, ARBs can substitute in for an ACE inhibitor, no problem. We're going to find why you might choose an ARB over an ACE inhibitor in just a few minutes. Most of it has to do with side effects, so I will say. Typically, ARBs are going to be better at reducing the effects of angiotensin II at the actual receptor level itself. So again, you kind of overcome those kind of accessory pathways for generating angiotensin II. And they also kind of indirectly activate these AT2 receptors. Not really so important clinically. This doesn't really ever come up all that often. The one thing you will see here is that ARBs do not inhibit the breakdown of bradykinin. So you may consider this kind of a disadvantage because we saw that bradykinin led to some degree of hypotension, or at least vasodilation, I should say. But bradykinin was also responsible for what side effect? The cough, right? And also possibly the angioedema. So this is one of the reasons why you might switch a person over to an ARB. If they could not tolerate the ACE inhibitor due to the cough, or they have a history of angioedema, there is some people may feel comfortable switching a person over to an ARB if they had angioedema. Certainly the cough, you could switch them over, and they really shouldn't have any more issues with that because the bradykinin is unaffected at that point, right? So the other thing, ACE inhibitors are going to be renally eliminated. ARBs are going to be more limited, somewhat by the kidneys, but also predominantly by the bile. So that could be an option if you have patients with really poor kidney functions. Might be a decent option. Maybe they could not tolerate the doses of ACE inhibitors. This might be a better deal for them. Okay, so again, I'm not going to quiz you on if they're pro-drugs or non-pro-drugs. I just kind of put this here for just completeness sake. But what do you notice about the names of all of these? Artin, yeah, so ARTAN are usually going to be the end of the names here. So you have candesartan, olmesartan, losartan, azilsartan, or azilsartan. You have iprosartan, irbesartan, telmisartan, and then valsartan. Again, if you can notice the sartan, you know it's an ACE inhibitor or angiotensin receptor blocker. You kind of know what that means, right? I like candesartan most because it sounds like candy, which your patients are probably eating too much of, which led to their hypertension and diabetes. So kind of think about it like that. So again, therapeutic uses, again, all the same therapeutic uses that you would see for an ACE inhibitor. The only reason why we usually recommend ACE inhibitors is because they've been around for longer and we have more clinical evidence to support their use. There may not be as many as big studies to show that ARBs are going to be just as effective, but again, clinically they're substitutable one for the other depending on what they can tolerate. So again, all the same use here. A lot of these ACE inhibitors or ARBs, you're going to see them put in combination pills along with a diuretic. So usually like an HCTZ plus, irbesartan or say lisinopril plus HCTZ. These are very common combinations because they have nice synergistic mechanisms of action. You get a little bit of thiazide diuretic effect. You get the nice ACE inhibitor effect. So they complement one another very well. So again, it's a very common combination that you'll see with them. Very similar therapeutic uses as far as LV function, diabetic nephropathy. These are also going to be kidney protective, very good for patients who are post-MI or they're at risk for cardiovascular disease. Like this, these are good drugs. As far as hyperkalemia goes, also still a concern, right? Because they're going to have less aldosterone being released. So again, that makes sense why we'd have a hyperkalemia. Hypotension is a risk here. And then again, you can still see some impairment in that renal function because those AT1 receptors are going to be what's affected by angiotensin II on those efferent arterioles. Okay. Again, still no-go for pregnancy. So I mentioned with heart failure, start with low doses, titrate up slowly, see what they can tolerate. And again, and they can use this for cough. Really does not cause cough. I should say does instead of do. But anyway, so it does not cause cough, mainly due to that bradykinin effect, which is, again, the positive, a lot of reason why a lot of patients switch over to these. And then lower incidence of angioedema. Some people feel comfortable switching from an ACE inhibitor over to an ARB. Again, you have to weigh the pros and cons of that. Decreased cardiac morbidity and mortality versus possible reemergence of the angioedema. Again, it's a very difficult line to balance. It depends on how bad the reaction was the first time, etc. So again, just depends on, and probably someone who works in cardiology all the time might give you a better answer than that. They might have more strict guidelines on when they would switch someone or not. Perhaps someone like Professor Gerke might be able to tell you. Okay, moving on. Any questions on the renin-angiotensin aldosterone system inhibitors? Fantastic. We're making great time, I think. Calcium channel blockers. Any idea what these do? See, sometimes we try to make it easy for you from the pharmacy world. We try to say, listen, we're telling you exactly how. Okay, so there's several types of calcium channels that are out there. The main ones we're going to be focusing on here is going to be L-type calcium channels. We talked about other things like T-type calcium channels, which we found in things like the muscles and whatnot. The main one we're going to focus on here is going to be this L-type channel, right? So think hypertension, think L-type calcium channels. Notice we also have other ones like, remember that ranitidine receptor we talked about? This is really important for causing malignant hyperthermia. I don't know if I ever mentioned that during the physio class, but if someone has a really bad reaction to general anesthesia, this can be one of the things that they have an issue with, is this ranitidine receptor. Regardless, so we're going to focus mainly on this L-type channel here. Notice it's going to be some of the physiological roles. AV nodal conduction, it's going to be really, really important. Excitation, contraction coupling, this is going to be really, really important for our effects on both the heart and on the vascular endothelium. There's three main classes of drugs we're going to run into. Clinically, you're going to divide these into dihydropyridines and then non-dihydropyridine. So we'll see the two drugs that fall into this phenylalkylamine and benzothiazepine just a second here. So L-type calcium channels found on the vascular smooth muscle. These are going to be predominantly because, again, calcium typically does what to muscle? Contracts it, right? Because we need calcium to help contract the muscle. If you block calcium influx, muscle relaxes, right, generally. We're also going to find these channels on the cardiac myocytes. Typically, calcium did what during the cardiac cycle? Also helped with depolarization and contraction of the cardiac muscle, right? And again, we'll also see these are going to have effects on the nodal tissue itself. So mainly the SA node and the AV node are going to be affected by particular calcium channel blockers. So again, going back into our heart physiology, we'll look at this more so when we get into the antiarrhythmic section. And again, a couple of these calcium channel blockers will be classified as antiarrhythmics based on their actions here, as we'll see on not only the nodal tissue, but also on just the actual myocytes themselves. But again, we saw that the SA node and the AV node are primarily do what for us? They're pacemakers, right? They set the pace for the heart. So if I can affect that, if I can block, say, calcium influx into the SA node, what do you think that would do to my heart rate? Should slow it down, absolutely, right? So if I were to affect, say, calcium influx, say, into the ventricular muscle, what do you think that would do? Wouldn't really affect rate, right? Because again, that's not going to be big, because we're more focusing on the pacemaker cells for that. What do you think it would do to, say, contractility? Should decrease contractility, right? So again, we're going to see some of the calcium channel blockers that affect the heart. It's going to cause decrease in heart rate. You're also going to see a decrease in contractility, okay? So that's going to be important to delineate those effects when you're either looking for adverse effects or looking what drug might be good for a particular patient. This is important stuff to remember. So again, looking at, say, like the SA and AV node, just looking at when you're having, obviously, the big thing that kicks off the action potential in the heart cells are going to be what? Sodium is going to be the big one, right? Remember, sodium influx is the big thing. So again, remember that slow, leaky sodium channels on the pacemaker cells? Hopefully you guys remember if you're physio. Okay, go back and watch the videos if you need a little refresher there. But again, calcium is really important. Calcium, big influx here. So again, if I can block this calcium influx, I can slow everything down. It takes a longer time for the action potential to occur here. Similarly, calcium is really important for causing that plateau effect. So if I can maybe slow down the influx of potassium, you can see that you're not going to get as big of a plateau. It's going to go down a little bit faster. So contractility again is going to be lesser than it would be if they were unblocked. You can just remember these T-tubules that are going to be found there. This is where that calcium influx is occurring, which can then cause things like calcium release from the sarcoplasmic reticulum. You guys remember all that good stuff. So again, I will not focus on it too much here. The other thing we'll see, the myocytes, again, less calcium coming in here, less of it being from sarcoplasmic reticulum. There's less effect on the actin and the myosin. This is the other thing I wanted to focus on was the smooth muscle here within the vasculature. So again, calcium is being really important. Again, the smooth muscle here is going to be working a little bit differently than what you'll see with the, say, the skeletal muscle or the cardiac muscle. Again, the big thing though is that less calcium is coming in here. You're going to have less activation of the muscle. You're going to have vasorelaxation essentially, vasodilation occurring. So what we can see is that calcium channel blockers, their effects on the veins is that at therapeutic doses normally are going to be not really affecting the venous tone quite so much, but what we can see is that they're going to have good effects on, say, like the arterioles, right? So they can have good effects to decrease afterload. They really don't affect preload too much, right? Because again, preload is just, how would you define preload? Yeah, the volume kind of getting back to the heart, right? So increase volume. So again, you can affect that by your venous tone, right? So the veins are more constricted. Obviously, that's going to cause, they have less storage capacity. You're going to be sending more fluid back to the heart. Otherwise, if you're looking at afterload, it's going to be all on the arterial side. Oh, interesting. Yes. So anyway, so afterload's a big thing that a lot of our calcium channel blockers are going to be affecting, not necessarily preload so much. We're going to see with a few other classes of drugs that might differ a little bit based on their mechanism. So what we can see here is that arterial blood vessels tend to be a lot more sensitive here. And we're going to see that depending on the type of calcium channel blocker we're going to talk about, some of them are going to primarily just work on the vasculature alone. Some of them are going to work both on the vasculature and on the actual cardiac tissue. Okay, so it's going to be important to delineate those effects when you're looking at things like adverse effects, therapeutic uses, etc. Okay. So again, I mentioned that you can break these down into dihydropyridines and non-dihydropyridines. We'll go into more detail here in just a few seconds on which go into which group. But essentially what you're going to find is that the non-dihydropyridines, these are going to be working more on the cardiac tissue and on the vasculature. So non-dihydropyridines, think slowing down heart rate, slowing down contractility, and also decreasing afterload, you're decreasing blood pressure. Okay. The dihydropyridines are going to have no effect on the AV nodal conduction. A little bit of effect maybe on the myocytes, so it may have a little bit of effect on contractility, but at therapeutic doses, only is really going to affect the vascular smooth muscle. So the dihydropyridines, or DHPs, are going to be mainly just affecting blood pressure, right? By affecting that total peripheral resistance, they're working on the arteries to dilate them, decreasing afterload, right? So the main uses we're going to use these for, and again, this will be more, this is going to be guided by which particular type of drug we're talking about, whether it's dihydropyridine or non-dihydropyridine. We're going to see things like angina can be a use for these, hypertension, arrhythmias. Primarily what you're going to see is that when dealing with arrhythmias, obviously they can originate from several different places, but when we talk about ones that are originating, say, from the atria, we call those supraventricular, right? So you're going to find the calcium channel blockers, the non-dihydropyridines in particular, are going to be good at treating these supraventricular tachycardias, because again, we saw they worked on the nodal tissue. We'll focus more on that when we get to the antiarrhythmic section coming up in a few lectures. These are also going to be potentially used for diastolic heart failure, cerebral ischemia, migraine prophylaxis. There's lots of different uses for calcium channel blockers rather than just hypertension. And we'll get more into detail on these in a little bit and talking about when they would be appropriate for each indication. So these are some pretty good tables to kind of delineate the different effects here of the different types of calcium channel blockers. So the non-dihydropyridines can be divided up into diltiazem and verapamil. Okay, so these are the two non-dihydropyridines. You're going to find they have okay effects on vasodilation. They're pretty decent at reducing blood pressure. They're going to have good effects at decreasing cardiac contractility. And they're going to have good effects of decreasing automaticity in the SA node and the AV node, right? So these non-dihydropyridines, you're going to see slowing down the heart rate, decreased contractility, still some vasodilation effects, so you're still going to see some decrease in blood pressure. Okay, so they have a nice kind of balance effect between the heart and on the blood vessels. Dihydropyridines, on the other hand, and I'll show you which individual drugs fall in that category in just a little bit, are mainly just going to affect vasodilation, okay? You're not really going to have much effect on anything else than just the vasodilation. Now, you can have a reflux effect. So imagine if you were to, say, decrease your afterload pretty significantly, you were to decrease total peripheral resistance. How does the heart respond to that? So if I decrease TPR, what has to go up to compensate for that? Cardiac output, right? So cardiac output is your stroke volume times your heart rate, right? So that cardiac output has to go up some way, and usually what happens, the heart starts to beat faster. So, and this is important because I actually see this quite a bit when I have a patient who, say, overdoses on their heart medication, right? And say that we don't know what they overdosed on, we just know they did. And they come in and they're hypotensive, but they're really tachycardic. a lot of times that screams something like a dihydropyridine, because I can say, well, their blood vessels are really, they're wide open, they're really dilated. I know the heart has to respond some way, and that's by increasing heart rate. Some increase in contractility, but mostly going to be this increase in heart rate. And so again, you can kind of give an idea of like what type of drugs am I treating potentially as far as overdoses go. And we do that pretty often during in our tox world. But again, you can see this clinically as well. In patients who are on a dihydropyridine, you can see their blood pressure say maybe bottom out. Heart rate's going to respond by becoming more tachycardic, right? So, and you can see that with hypovolemia. You can see it with lots of different reasons, but this is a particular drug-induced one. Does that make sense? Hopefully that makes sense. Okay, so we'll go into each of the calcium channel blockers in more detail when you guys come back from your 10-minute break. All right, any questions from the first half? All right, we got miles to go, so let's hit it. So we have diltiazem. This, again, don't focus on the chemical name. Really, the only thing you need to know is it dihydropyridine or is it non-dihydropyridine? So diltiazem would be non-dihydropyridine, absolutely. So diltiazem, cardizem's another brand name for this one. It is available either IV or PO, or my EMS people at. Anyone ever used cardizem before? You may have seen it occasionally. Cardizem used for like supraventricular tachycardia, things like that. So it's a very common one, especially in the emergency medicine world. We use this for things like angina. Why do you think it might work for things like angina? We'll talk more about this in more detail in another section, but. Well, because it's slowing down the heart rate. And what does that do to oxygen demand by the heart? Decrease, yeah, because it's not working as hard. So again, you start to see where some of these drugs are going to have kind of dual benefit. Not only they're lowering blood pressure, but they can also work for other things as well due to their effects here. But mainly hypertension, angina, and then SVT are going to be our primary types of indications for diltiazem. So don't focus too much on the kinetics. The big thing I want to note here is that this is going to be have a lot of drug interactions associated with it because it's primarily metabolized by CYP3A4, as we'll see, and it also can have some activity to inhibit it. Adverse effects. Main things you're going to see are going to be related to the either the effects it has on calcium or the effects it's going to have on the myocardium or on the vasculature. So imagine peripheral vasodilation, right? It's going to cause vasodilation due to blocking calcium. So you can see things like flushing, peripheral edema, things like that are pretty common. And then obviously it's going to have some negative inotropic effects, right? The heart's not beating quite as hard. So you see things like a first-degree AV block, bradycardia. Again, some patients are going to be more prone to this than others. If you imagine someone who had CHF to begin with, they already had pretty poor left ventricular function. This could depress that even further and cause a CHF exacerbation. You're going to typically find that non-dihydropyridines are not great drugs for CHF patients. Okay, we'll talk about some other drugs that are going to be better for them from a mortality standpoint. The other thing to note here is you can see some adverse GI effects because again, what ion helps to cause contraction of the smooth muscle in the GI tract? Calcium, right? So if you're blocking that, it can have some bleed over effect into the GI tract. Constipation can be a really big side effect here, right? So watch out for that. And then as far as CNS effects go, a lot of that has to do with cerebral blood flow. So obviously if you're causing hypotension, you can see dizziness, syncope, all those kind of effects there. Okay. Again, some sexual dysfunction you can see occasionally. A lot of this has to do with things like blood flow, being shunted around to different areas. Obviously it's not going to the sexual organs. You can see some disturbances happen with that. And then very rarely you can have things like gingival hyperplasia, maybe some skin reactions, but other than that, it's pretty well tolerated. Mainly the cardiac effects, the effects on the blood vessels are going to be the primary thing you're going to be seeing here. So contraindications, they already have advanced heart block. Obviously, wouldn't want to worsen that. They're hypotensive, probably don't want to worsen that. And then just relative contraindications, again, usually avoid it in heart failure patients. You don't use it too often. And then they can worsen things like liver dysfunction, may not be able to clear the drug as well. And then GERD symptoms could be worsened by this. So as far as diltiazem goes as a causing drug interactions, it's a 3A4 inhibitor. So it's going to be able to affect things like our statins we talked about before and several other medications, which we may not have jumped to just yet. So just note it's a 3A4 inhibitor, can cause other levels of drugs to increase, absolutely. It also affects that P-glycoprotein. So again, similarly, by blocking an efflux pump, it's going to cause levels to go up of several things as well. So just be careful of that. Can have some pharmacodynamic interactions, which means that its mechanism of action can be synergistic with other drugs. So if you had to imagine something like amiodarone, which we'll talk about in the antiarrhythmic section, things that are going to have negative inotropic effects on the heart, it's just going to be synergistic with diltiazem, right? So it kind of makes pretty good sense when you're looking at that. As far as drugs that can affect diltiazem, other 3A4 inhibitors can also affect diltiazem. So not only is it inhibiting 3A4, but other things that inhibit could be a big issue. What do you kind of notice about these drugs here? What do you think you use these for? For virus, yes, these are HIV medications. When we get to talking about HIV, you'll see there's a ton of drug interactions, mainly because a lot of these end up inhibiting CYP enzymes. So the other non-dihydropyridine is going to be verapamil. Calan is a common brand name for that. Again, available IV or PO. Again, you might have seen as one being used IV for things like SVT, things like that. So again, similar indications to diltiazem. And again, clinically, you kind of think of these two pretty much interchangeably for the most part. Again, we on a hospital formulary standpoint, you can utilize either one of these. It just depends on usually whatever happens to be cheaper or whatever your cardiologists like to use, etc. So again, notice here very similar effects as far as effects on the myocardium and on the vascular smooth muscle as diltiazem. Again, can affect 3A4, but also you're going to notice it can have effects on 2C9 as well. So again, even more risk for some drug interactions, as we'll see in just a minute here. So still has peripheral vasodilating effects. It can have that negative inotropic effects, or just say constipation. Again, so all very similar side effects to diltiazem. Okay. Very similar contraindications as well. So again, you can kind of think of these two non-dihydropyridines very similar in your mind. So you can see that it will be a 3A4 inhibitor, so it can affect our statins still. It can affect PGP just like diltiazem can. So again, you need to be careful of these drugs. This may not be such a big issue if you're doing like, say a day or two worth that they come in with SVT to the ER, but for more chronic use, this is where this is going to become much more important. And obviously other things that can inhibit 3A4 can affect this as well, so again, be careful with those. Okay, so those are the non-dihydropyridines. Flipping over to the dihydropyridines, the DHPs, you're going to notice again a similar naming convention with these guys. So you have things like amlodipine or Norvasc or nifedipine, nicardipine. These mainly are going to be used for things like angina and hypertension. We'll talk more about angina later on, but hypertension is our main focus here today. You also have things like felodipine, isradipine, and isoldipine. Again, still used for hypertension. Nimodipine, this one's kind of interesting. We use this in the surgical ICU after, or actually the neuro ICU, I should say, for subarachnoid hemorrhage. This has some effects on cerebral blood flow. Most of these are going to be PO only, except for nicardipine. This is actually one we can use as like an IV drip to help control hypertension for some of our more severe patients. And typically what you're going to see here, and again, because these are mainly focused on the vascular smooth muscle, they're very potent in causing vasodilation. We really like these extended release preparations or drugs that have a long half-life, because if you give short-acting forms, you can actually bottom out their blood pressure very significantly. It gets really high peak effects, can be very potent. You can bottom out their blood pressure, they get really tachycardic, they pass out, and it's no good. So watch out for those. You notice here vasodilation, not much else as far as cardiac effects go. Now, does that mean that you have no cardiac effects ever? Certainly not. I mentioned dealing with overdoses. You find there's a lot of bleed over effects, and I've had one young lady who decided to take all of her grandma's amlodipine. I think she had like a 3-month supply all at once. And as far as overdoses go, these drugs are like super scary. And she ended up having very significant bradycardia and hypotension, even though it was amlodipine she had taken. So just be careful. There can be some bleed over effects with these. And again, dose and selectivity is all relative. All right. These are going to be substrates of 3A4, but these are not going to inhibit 3A4. So that's kind of one of the main differences in drug interactions here, that they can be affected by CYP3A4 inhibitors, but they will not inhibit it itself. They should not have as many drug interactions as you would see like verapamil or diltiazem. Yeah, you'll notice here, I just kind of put that the potency can change pretty drastically. So it's really, you have to be careful when you're switching patients, say, from one type of dihydropyridine to another, because the doses can be very, very different. 2.5 milligrams of amlodipine is a lot different than 30 of nifedipine. If you goof up that conversion, you can end up getting patients either really sick or get them hypertensive. And I just know that the half-life can range pretty widely as well. So things like nifedipine has a very short half-life, maybe only 2 hours, versus say like 50 hours from amlodipine. Right, so obviously longer-acting things are going to be better for more kind of chronic management. Usually once daily dosing, all those kind of things are beneficial. The effects here, not going to see a ton of direct cardiac effects. You may see some tachycardia as kind of a reflex mechanism to the hypotension you see there, but they can cause a lot of peripheral edema. You can still see some GI effects like constipation being a potential risk there. And then the gynecomastia, you see it's a little bit more nifedipine than diltiazem, so again, be aware. It may have some androgenic effects, but again, pretty rare for the most part. It usually is dose dependent, so the higher doses, you're more likely to see that. Okay. Now, some contraindications. They have severe aortic stenosis. Anyone know why this would be a contraindication? Anyone know what aortic stenosis is? Yeah, basically kind of blocking off portion of the aorta, so that way it's going to be more difficult to pump blood out of. Imagine if you had a big decrease in your arterial resistance, the heart really can't compensate for that. So you could have a case where you're really kind of decreasing the perfusion of the tissues, decreasing oxygen delivery, causing ischemia. So again, it kind of makes sense when you think about the mechanism of the drugs versus the pathology that you're dealing with the patient. That makes sense? So you kind of think about, hopefully, I don't see a lot of light bulbs going off. That's okay. Just know that's going to be one of those cases where you got to be careful, look at the underlying pathology and make sure why this might be a good idea or a bad idea for your patient. And whenever you used to watch the Animaniacs, there's like good idea, bad idea. Think about drug decisions like that, right? Like good idea, giving the patient beta blocker. Bad idea, aortic stenosis and dihydropyridines. Anyway, also keep in mind that we usually avoid the dihydropyridines in patients who have like unstable angina. What is an unstable angina versus stable angina? Yeah, so if you're having symptoms at rest, usually considered to be unstable. This can actually worsen some degree of coronary perfusion, so you want to be careful with using. And again, if anything, your dihydropyridines causing vasodilation causes the heart to speed up. What does that do to myocardial oxygen consumption? Goes up, right? And so again, that's the ultimate reason why you're having angina in the first place, because you're not delivering enough oxygen to the tissue. So again, kind of think about those things before prescribing. Okay. So I mentioned as far as drug interactions go, mainly the pharmacodynamic stuff is going to be having synergistic effects with other drugs that lower blood pressure. So again, beta blockers, digoxin, amiodarone. So we'll think about these things as we talk about the other classes of drugs as we move forward. But if it lowers blood pressure, it's going to interact with our dihydropyridines. Obviously, a CYP3A4 inhibitor could affect dihydropyridines, cause levels to increase, and again, see more physiologic effects. You got to be careful with that. All right. Any questions on our calcium channel blockers? Okay, so with the beta blockers, there's going to be some ancillary information that'll be on these slides. I'm going to tell you what to don't worry about for our testing purposes, and I'll show you what to worry about for the test. Okay, so keep note of that. We're out of time. Anyway, so as you might imagine, beta blockers work how? Block the beta receptors, absolutely. So we're going to cause competitive inhibition, not only of our cardiac beta-1 receptors. This is going to cause cardiac output to go down. Should see a reflex increase in TPR, but you can also end up seeing some effects on the beta-2 receptors as well. Usually beta-2 effects on the vascular smooth muscle is what? Usually vasodilatory. If I block that, you may see some increase in TPR as well because of that effect. We'll look at selectivity of our beta blockers in just a few minutes, but this is why you can see things like impaired exercise tolerance, right? So if I had a patient who is being given a beta blocker and their heart rate was being kind of limited, right? So they have a fine resting heart rate on a beta blocker, but all of a sudden they want to go run a mile and their CNS, or the sympathetic nervous system, is telling the heart to speed up, but it really can't do anything because the beta receptors are blocked. You can see why they would have exercise intolerance, right? You also see that these can decrease angiotensin II concentrations by blocking some of these beta-1 receptors that help to mediate renin release, right? So I mentioned that sympathetic nervous system can affect renin release from the kidneys. This can help to block that a little bit. Also, with non-selective beta blockers, you can have effect on the pulmonary beta-2 receptors. This is where you study that risk for bronchospasm and asthma. You guys remember when we talked about that? Asthma? Yeah. So other things we can see, blockade of presynaptic beta-2 receptors actually helps to decrease norepinephrine release. So again, a little bit of that kind of sympatholytic effect can be beneficial for our patients. And then we'll see some CNS effects. This is mainly going to be mediated by how lipophilic our beta blocker is. The more lipophilic it is, the more likely it is to penetrate the CNS and cause some of these side effects here. Obviously, the blood pressure is low, the heart rate's low. They can get dizzy from that standpoint, but you'll see some other kind of actual CNS effects here, where you can see like depression can be worsened in some patients. You may even see patients develop hallucinations, especially older patients. Maybe have like sundowning or dementia that can be worsened by this, nightmares, things like that. And also we're going to see it kind of helps with our baroreceptor response. We mentioned that when you have chronic hypertension, what happens to your baroreceptors? They reset to a higher set point, right? So this kind of helps to, with chronic use, helps to kind of reset those down to a lower point to where your body's not trying to fight itself quite so much with these reflex mechanisms in that negative feedback loop. So the differences in beta blockers is primarily going to be the selectivity, if it's beta-1 selective versus non-selective. We're going to see that the metabolism may change. Some of them are going to be mostly hepatic, some renal. Again, for our purposes, I'm probably not going to focus so much on that for the test. And then I'm not going to talk about intrinsic sympathomimetic activity. Just blank that from your memory. Just pretend those lines were not there. This is not going to be super clinically useful for our purposes for this class, at least on the test. We'll also see that some of the beta blockers have what we call a membrane stabilizing effect. This can be useful for some antiarrhythmic activity. There's going to be one beta blocker in particular we'll talk about that is used as an antiarrhythmic. Some of that has to go back to this this membrane activity to help kind of deal with some of these arrhythmias. And then some of them are going to be nice. We'll have what we consider third generation beta blockers, which would be beneficial because they actually help with some kind of ancillary effects to help manage blood pressure, like nitric oxide production. Do you remember what nitric oxide does to blood pressure? Decreases, yeah. So that's why we go like nitroglycerin. That's why things like phosphodiesterase inhibitors are good because they help the nitric oxide to work better. Then we'll talk about that a little more later on. Some of them are going to be alpha-1 antagonists. You guys remember what alpha-1 does? Vasoconstricts, right? So you can block that and cause some vasodilation. Some of them will be beta-2 agonists. Some help with calcium, potassium, antioxidant activity. So we'll look at a few of those effects a little bit later on. So the first set we're going to look at is going to be our first generation drugs. Now, a general rule of thumb, and this is only going to carry you so far, as we'll see, there's some exceptions to this, but A through M, or beta blockers that begin with the letter A through the letter M, as in Mary, tend to be selective beta blockers. N as in Nancy through Z tend to be non-selective beta blockers. Okay. This will hold true until we get to the third generation drugs, as we'll see in just a few minutes here. So what do you notice here? Nadolol, penbutalol, pendolol, propranolol. I'm sure most people have heard of propranolol before, or as I've mentioned it before. These are going to be non-selective beta blockers, right? So what type of patient would you avoid these drugs in? Right, so you think asthmatic patients being one of the big ones. Sotalol is going to be an interesting one because that one is actually the antiarrhythmic that we'll talk about in a couple slide sets after the test. So just kind of keep that one in the back of your mind. You guys remember we saw timolol before? Yeah, we use that in glaucoma, absolutely. So again, don't worry about this ISA category here, and just know that the lipid solubility is going to be affecting the CNS penetration. So things like propranolol, like this is, you guys ever heard of the Beers list? It's not like what you go to the microbrew and they just hand it out to you. It's not that sort of Beers list, but this is a list of drugs that are not preferred in elderly patients due to usually a lot of CNS effects. So this is the reason why propranolol gets put on this list, because it has high lipid solubility. It's able to cross that blood-brain barrier relatively easily, and you can see worsened dementia. You can see hallucinations, nightmares in some of these elderly patients. So just be aware of that. It's it's not a reason to never use that drug, but it's a consideration to make, especially for geriatric patients. Now here are our second generation or first beta-1 selective drugs. Again, notice the A through M kind of nomenclature here. So acebutolol, atenolol, bisoprolol, esmolol, metoprolol. These are all going to be beta-1 selective. So these would be relatively safe in an asthmatic patient. You're also going to notice some of these come in an extended release preparation. So if you ever see like a metoprolol extended release, that's a good one we'll talk about for CHF a little bit later on. And some of these are actually available for IV use as well. So like esmolol is a really good short-acting IV beta blocker we'll use sometimes in the ER to get patients' pressures down pretty quickly. But again, nice thing, we can use it in asthmatic patients without really any risk there. If it has RE or HM, don't worry about it for the test, but just know it means either renal elimination or hepatic metabolism. Again, I'm not going to focus so much on that one for our test here. Okay, so this is where the rule gets broken. So these ones you just have to kind of remember outside of that. These are third generation drugs that have kind of ancillary activities. So you have things like cardiolol, which we saw before also in glaucoma. That was another drug that falls in that category here. This one, has some nitric oxide effects. Also has a beta-2 agonist effects, right? So it's kind of different than a lot of the other beta blockers we've already seen. Carvedilol, this is a really big one. You'll see used for CHF patients or for hypertension. So see a lot of Coreg being used out there. This one's nice because it causes alpha-1 blockade, right? So that helps bring pressure down as well, right? Because they don't have that vasoconstrictive effects there. Labetalol is another good one. Sometimes PO, but we use this one IV pretty consistently in the hospital as well. Again, very nice because it causes beta-2 agonist effects. So what does that do to the vascular smooth muscle? Causes dilation, right? Because you're beta-2 agonist, and then also alpha-1 blockade causes vasodilation as well. So again, you can see why this would be very effective at lowering blood pressure very quickly. And then Pataxol is another one. You can see used for glaucoma. It's got some vasodilatory effects, calcium blocking effects. So there's a little bit of bleed over here. Just be aware these don't follow that same nomenclature. They're not going to be strictly as beta 1 selective as we would see with the second generation. That makes sense? Okay. So the reasons why we'd use a beta blocker, and again, usually you have to look at other patients, other comorbidities to decide if a beta blocker is going to be good for them. Certainly you can look at just a hypertensive patient. They usually have other stuff going on as well as going to kind of guide you to using a calcium channel blocker versus a beta blocker. We'll talk more about that as we go forward. But one of the main indications for beta blockers is hypertension. Usually not recommended first line though. Usually things like hydrochlorothiazide is recommended first line for a particular type of hypertensive patient. Usually ACE inhibitors or Renin-Angiotensin system drugs are going to be also recommended as first line for a different type of hypertensive patient. Okay, beta blockers are useful adjuncts, not usually used by itself. They work good, they work well in young patients, especially if they have, like, say, like a resting tachycardia, or just for some reason their sympathetic nervous system is kind of in overdrive. This would be a good reason to utilize a beta blocker kind of first line when they have too much catecholamines. This can kind of help with the renin effects as well. But again, a lot of younger patients aren't going to tolerate this well due to the exercise intolerance, right? So it's a good reason why people will discontinue use of this, because they try to get up, move around like they used to, and they just can't really respond to that. The heart can't really keep up so much. But can still be useful in elderly patients, especially if they're more sedentary, not really getting around. If the 90-year-old's probably not going to go run a marathon or anything anytime soon, so that might be a decent patient. So some of the effects you're going to see here due to, again, looking at it's a cardiac output, looking at Ang2 norepinephrine release. You're going to notice here that, again, with MAP or mean arterial pressure, typically you're going to see a pretty sustained decrease in your mean arterial pressure. What you can notice early is that you're always going to have kind of acute effects versus kind of the more chronic effects you're going to notice here. But again, with acute administration of a beta blocker, you can see decrease in your cardiac output. But again, that's going to kind of go back and kind of stabilize out pretty well. But the decrease in total peripheral resistance is going to be kind of the big thing here, right? So again, it's going to be a sustained decrease in total peripheral resistance to help lower that blood pressure. And then, looking at, this is the cardiac output thing here. So TPR, again, you may see an acute increase when this occurs, and that's mainly due to the fact that, when you cause the cardiac output to decrease, TPR is going to respond to that. But again, you'll end up seeing some diminishment of this. Again, overall, the blood pressure should be lower than when you start. Okay, other indications, we mentioned glaucoma already, so I'm not going to belabor that point. In some cases, even though beta blockers can cause migraines in a lot of patients, mainly due to the fact that migraines are generally caused by changes in cerebral blood flow, you can actually use this as a prophylactic. So by giving it to someone chronically, you can hopefully prevent a migraine from actually forming. We can sometimes use this for hyperthyroidism or thyrotoxicosis. Anyone know when you have like really severe thyroid issues, what they call that? Yeah, thyroid storm. And so we can actually use this. It helps to deal with a lot of the the cardiovascular effects, like the blood pressure, the hypertension, the tachycardia. Kind of another interesting thing that you can see it helping is actually helps to block conversion of T4 to T3. So remember what the active form of thyroid hormone is? T3, yeah, T3 is way more active than T4 is, so you can actually give propranolol IV and actually prevents that conversion over, so it helps to limit the amount of really active thyroid hormone in the system. So it could be another indication where you might see it being used. Another big indication for beta blockers is going to be angina, because again, imagine if you're directly blocking those beta 1 receptors in the heart, slowing it down, decreasing the inotropy, the chronotropy. That's going to do what to oxygen demand? Goes down, right? So that's perfect treatment for angina. So we'll look at those patients later on. They're going to be really good candidates for this. So again, I won't talk too much about that. We'll get into more of that later. We will use this after acute myocardial infarction. Again, typically these patients, when they come in for an acute MI, beta blockers, as long as they're not like hypotensive and cardiogenic shock already, this is one of the first drugs that will get put on, possibly during the event, sometimes afterwards, depending on what their blood pressure looks like. But this is good because it helps to prevent kind of recurrent symptoms of the MI, right? It helps to decrease oxygen demand by the heart, decrease contractility. So you see very frequently patients either during an MI or post-MI may be put on a beta blocker. And then this can also be used similarly to your non-dihydropyridines. It helps to block nodal effects on the heart, so you can end up seeing being used for supraventricular arrhythmias. Other things we can use beta blockers for include acute panic attacks. So again, if you imagine someone, and so again, if you have someone who has like performance anxiety, this could be another indication where you use a beta blocker. So anyone ever like had to or heard of someone who's like needed to go give like a big speech and they get really, really nervous beforehand, like how do you normally, what's the physiologic effects of that? Tachycardia, what else? Sweating, the flop sweat. You're shaking, right? So again, a lot of that has to do with that sympathetic nervous system because you're in a fight or flight response. Beta blockers can help to block a lot of that. And so like, for instance, when I was in pharm school, we had a class called pharmacotherapy where basically you would get called on out of a group of 50 of us and you'd have to like stand up in front of everyone with their lab coat on and they'd ask you, okay, well, why did you choose this drug? And I'm just like, and that was usually the end of it. But I got better at public speaking as time went on. But some people got really, really nervous, and so they would end up being prescribed beta blockers to help kind of block those effects. Helps block the skeletal effects. They're not sweating as much. They don't really have the same tachycardia. So again, you might see musicians do this. Lots of different people might need this for performances. So we'll talk more about that a little bit later on, but it could be another indication. And then CHF, so this is kind of we'll talk more about CHF a little bit later on. There's only 3 beta blockers that are actually approved for use in CHF. Again, typically you think a patient with CHF has poor left ventricular dysfunction. What would a beta blocker do to left ventricular dysfunction? Should depress it even further, right? So you think, well, why would I use that for a CHF patient? Well, and that's why we typically start with very, very low doses and gently titrate them up on one of these 3 beta blockers. And what we actually found is we have mortality decreases, pretty significant decreases over the course of several years. And so this is why we recommend these nowadays. Normally you'd expect to see and originally they were contraindicated just due to those depressant effects. Nowadays we realize by kind of taking some of that pressure off of the heart, you help to prevent some of that remodeling that happens over the long term. And so it can be again very have good effects on mortality, and this is why we use them nowadays. Because initially you think they worsen symptoms, and they can if you titrate too quickly. But in the long run, this is going to be better for them. Okay. As far as adverse effects go, obviously we talked about the bronchoconstriction. This is going to be more of the non-selective beta blockers. Again, some patients who are asthmatics, they may receive a non-selective beta blocker and be totally fine. Just some people are going to be more likely to have a reaction. Some people may find like their albuterol or drugs like that are going to be less effective if those beta receptors are being blocked. And then obviously if they have negative cardiac effects here, so negative inotropy, negative chronotropy, so just be aware you can induce things like AV block, etc., due to the effects of the beta blocker. So you can also see some effects on glucose metabolism in these patients. This is why beta blockers may not be a good option for a lot of diabetic patients. So for instance, it can actually induce hypoglycemia, say like in a type 1 diabetic patient. Because again, with a type 1 diabetic, do they have any issue of insulin resistance? Typically, no, right? Their problem is insulin production more than anything else, right? So they can have an issue where normally their liver is going to be producing glucose in response to usually your sympathetic nervous system. Things like norepinephrine can help to stimulate this. By blocking those beta receptors, you can actually end up blocking this, end up leading to hypoglycemia. So that can be one issue you run into with type 1 diabetics. On the other hand, with hyperglycemia with type 2 diabetics, you can see the beta blockers actually can help to block insulin release. And again, that's going to cause their glucose to rise anyway in those cases. So the other big thing you have to worry about is what are the signs and symptoms of someone who's hypoglycemic? They're dizzy, they're shaky, they're tachycardic, they're sweating. That looks pretty similar to a panic attack, right? Or performance anxiety. Again, that's all the sympathetic nervous system, right? So what you can see is by blocking those effects, someone may become hypoglycemic, not realize it until they get very, very severely hypoglycemic. You're more likely to see those CNS effects. So this can actually mask that, and you have to be very careful with your diabetic patients. But hey, just so you know, check your sugars maybe more often, or depending on kind of what their situation is. This can mask the effects, and you may be actually hypoglycemic and not realize it. Okay. Okay, so some other things you can see, some adverse effects, impaired peripheral circulation. This could be related to blocking those beta-2 receptors. As I mentioned, those are generally vasodilatory. If you block that effect, you may see some decreased perfusion, which can lead to things like Raynaud's phenomena being maybe exacerbated. You may see skeletal muscle fatigue, and peripheral artery disease could be worsened. So you can actually worsen this kind of intermittent claudication. The other big thing to watch out for is with chronic administration of a beta blocker, what do your receptors want to do in response to that? They upregulate, right? So if you were to take away that drug all of a sudden, with a sudden withdrawal, you can see a rebound effect, where you see rebound tachycardia, rebound hypertension, and so this can lead to things like rebound myocardial infarction, right? Someone who's on a beta blocker for a long time, that had a previous MI, they come off of it, all of a sudden blood pressure jacks up, heart rate jacks up, and all of a sudden they have this myocardial ischemia again. So again, it's one thing to watch out for. Okay. I mentioned the CNS effect. This is only really with the highly lipid-soluble agents, so they could worsen depression, hallucinations, etc. So be careful in your older patients for that. And then also some ability to increase triglycerides. So get their hyperlipidemia already, like you just be wary and watch out for that. As far as drug interactions go, mainly it's going to be not necessarily CYP mediated, but just be aware of these interactions as far as the pharmacodynamic effects. So obviously, if you put a calcium channel blocker like a Thiazides plus a beta blocker, you're going to have synergistic effects on cardiac output, right? You're going to be diminishing it pretty significantly. Because not only do you affect cardiac influx into the cell, but you're also blocking the beta effect there as well. So you can see some synergism there. We'll talk about clonidine in a little bit. This is going to be an alpha-2, I should say alpha-2 agonist. I should change that. But basically, you can see again synergism. Where here we'll talk about clonidine in a little bit. But basically, you're just dropping blood pressure, dropping your heart rate. So be careful of these other antihypertensive meds. Okay, so any questions on beta blockers? I think we're making good time here. I hope. Maybe not. Okay. So next up, we're going to talk a little bit about our vascular smooth muscle relaxants and alpha blockers. The drugs we've covered already are the primary drugs we're going to use for hypertension, right? These are going to be some accessory meds. These are going to be meds we're going to use a little less frequently, but we'll talk about where they're go forward. So again, these are going to be, we'll talk more about this in detail as we go forward. But again, some of the drugs we're going to use are going to work from the CNS down, as opposed to working at the site of the actual receptors on the vasculature and on the heart. So we're going to have ones right here. These are going to be direct relaxants. These are going to be alpha-1 adrenergic antagonists. So as you might imagine, by blocking alpha-1 receptors, that causes blood pressure to drop, right? So again, this is going to be a reflex, going to be a reversible effect. And this is going to be something where we're going to see a big drop in TPR. But again, what do you think cardiac output's going to do to respond to that? Going to go up. So again, this is going to be even more dramatic effect than you're going to see with dihydropyridines. So again, these are going to be not really all that well tolerated by most patients, and why we save them is it's like a third, fourth string kind of antihypertensive. See a lot of reflex tachycardia, not going to be, and again, a bigger risk for hypotension. A couple of drugs we have in this category include things like prazosin or mini-press. Again, I'm not going to go super into detail on, obviously you can see things like, some changes in LDL, triglycerides. Again, all goes back to that sympathetic effects here. Again, not to be used by themselves, right? You can use a beta blocker by itself. You can use a calcium channel blocker and ACE inhibitor. These guys oftentimes are going to be adjunctive agents, not good by themselves. So yeah, prazosin. Orthostatic hypotension is a big deal with these drugs. Put this on an elderly patient. They go from sitting to standing without really being on it for a long period of time, or they just started. They're much more likely to see that orthostatic hypotension. This is where the nighttime dosing is usually going to be a little bit better for them. Mentioned that reflex tachycardia. This is going to also cause some pretty significant reflexes in your renin-angiotensin system. So the ability for these to cause sustained drops in blood pressure are not super great, just due to all that reflex, angiotensin, ADH, aldosterone, all that other stuff. So again, not great antihypertensives. Also, if you might imagine, blocking alpha-1 receptors can affect blood flow, especially to the penis, and so you can have impotence as a potential side effect. So these also have a lot bigger incidence of sexual dysfunction than you would see with like an ACE inhibitor or something like that. Obviously, interactions are going to go back to other cardiodepressants. Obviously, NSAIDs we mentioned affecting antihypertensive, so all that kind of makes sense for us so far. We have a few others that fall in the same category as prazosin. We also have terazosin. Some people say terazosin. I don't know which one's right, but there's also doxazosin. Again, these are all going to have the same mechanism, same side effects as prazosin. Some of them are going to be a little bit better because they have a longer half-life and are good for once daily dosing. You notice here that we can use some of these for benign prostatic hyperplasia. Why do you think that is? So we'll talk about this when we get to the urology section, but with the prostate gland surrounding the urethra, there's alpha receptors on there. And so when you activate those, they cause constriction, just like it does on the vascular smooth muscle, and that can actually impinge urine outflow. And so if you can block those receptors, you can cause that prostate to release and have better urine flow. So we have one drug that we use that's very specific for a subtype of alpha-1 receptor, this is alpha-1A, and so we have a drug called tamsulosin or Flomax. This is designed just for BPH and is good because it doesn't really affect blood pressure because it doesn't affect the alpha receptors that are found in the vasculature, just the ones that are found in the prostate, which is nice. Again, I mentioned before we had this third generation antihypertensives that are going to, or beta blockers, I should say, that were affecting the alpha receptors. So again, labetalol is a good IV agent that we use occasionally to help get blood pressure down very quickly, and then carvedilol as well. It's another very common one. It was on that list for the CHF approved beta blockers. Okay, next are going to be some central sympatholytics. These are going to be drugs that actually decrease outflow of the sympathetic nervous system. These you may see used occasionally, but there'll be some other ancillary uses than just hypertension, as we'll see here in just a minute. Basically, these are mostly going to be stimulation of postsynaptic alpha-2 receptors. Don't worry about these antidazzling receptors so much here, but the alpha-2 activation is really the big thing we're focused on. If you remember back to physio, we said alpha-2 activation typically is decreasing sympathetic outflow. So as you might expect, it would cause decreases in heart rate, blood pressure, because it's affecting the CNS, the sympathetic nervous system from the brain down, essentially. You can also see some other kind of neat effects here where you can affect things like the ventrolateral medulla. You can see here the nucleus, the solitary tract. So there's actually some indication for some of these for use in things like chronic pain issues. So you're going to see a lot of kind of adjuvant uses for these drugs and other conditions than just hypertension. So you can imagine clonidine is going to be kind of our poster child for this group of drugs by activating the alpha-2 receptors, possibly some of these imidazoline receptors. Again, a lot of decrease of norepinephrine on the blood vessels, decrease heart, cardiac output, all of that. So again, these are good for kind of just global depression of the sympathetic nervous system. So again, generally decrease CPR, decrease heart rate, decrease cardiac output. Nice balance across all the facets there. Now, some patients, these are not going to be first-line agents either in regards to treating a patient with hypertension alone, but some of these are going to be decent, if they could not tolerate other drugs for side effect reasons or allergy reasons, some of these may be okay for single use. So clonidine, you may see a patient occasionally on clonidine by itself for hypertension, but it's pretty rare for the most part. Again, efficacy depends a lot on age, race, gender, so again, it's not always predictable on who's going to respond well to these drugs. So general side effects, as you might imagine, working on the CNS and decreasing sympathetic outflow, mental status depression is going to be a big one. We've run into this pretty commonly with kids who get into clonidine. Like they get really mentally depressed. It almost seems like they're on an opioid. They even get respiratory depression from this. It can be pretty significant. Obviously, since sexual dysfunction can occur here, and they typically have a narrow therapeutic index. So we don't draw levels for these necessarily, but you got to be careful because even small changes in dose can cause big changes in their blood pressure and heart rate. And again, you can also see abrupt withdrawal syndrome here as well. It's very similar to the beta blockers because of the fact that by having decreased sympathetic outflow, all those beta receptors, alpha receptors are going to try to start upregulating because they're not being activated. So you can see the withdrawal effects. Really be careful with these. Okay, so as I mentioned, clonidine is a poster child for this group here. You're going to find other uses for it as well. You can see things like ADHD. I don't know if anyone's ever seen like a child on, they usually be like on an amphetamine type of drug in the morning time, and they'll put them on clonidine to knock them out at night. It's a common adjunctive drug for ADHD. We'll talk more about that when we get to the behavioral health section. This one's also nice because it actually comes as a patch. So you can actually put it on and actually have kind of sustained utilization. It's good for compliance if you're worried about a patient taking a pill every single day or twice a day. And also we use this a lot for our patients, at least specifically in the NICU or in the neonatal intensive care unit. We can use this for patients who come out whose mothers have been using like opioids throughout the pregnancy, and now they're coming out having neonatal abstinence syndrome. We can use this to kind of help blunt those cravings, right? Because moms are addicted, babies come out addicted essentially, and so we can have to blunt some of those effects by giving clonidine, right? Anyone ever seen someone who's like going through withdrawal from an opioid, or seen on TV or something? Like, what do they act like?
Agitated.
They're very agitated. Their sympathetic nervous system is really overactive, right? And so again, this can be very useful for helping to blunt those effects. So we use that quite a bit for our NAS babies. Again, sedation is going to be another big side effect. One of the primary things you're going to see with this. Okay, so I mentioned withdrawal effects. You can see some orthostatic hypotension, some impotence, bradycardia. Obviously, hypotension is going to be another risk with these ones. So again, just be very careful in titrating the dose with these, because again, you can have kind of a steep dose response curve, and even small changes can cause pretty big effects on your hemodynamic status here. There's also another drug called guanfacine. Brand name is 10X. Again, this is going to have very similar effects to clonidine, and this is another one you may see more commonly used for ADHD. If you ever see like Intuitive as a brand name for guanfacine, that's usually what it's being used for. Less sedation than you see with clonidine, and less of this withdrawal syndrome. Less potent in general, but can be another useful agent other than clonidine. Okay, and then we'll close out. We have some direct vasodilators that we can use. Working directly on the vessels to help cause vasodilation. In general, they're going to cause either direct arterial dilation, causing a decrease in TPR, or they may have more effects on the actual venous side as well. We'll kind of focus on which one that is based on the drug when we see it. Again, by causing a lot of vasodilation, you can have pretty predictable responses from the heart side of things. You're going to see increased cardiac output, tachycardia, and again, because of the fact that you have this kind of response from the body to try to hold on to more fluid and increase that Renin-Angiotensin system, these are not great drugs for being used for hypertension by themselves. Okay, these are good for kind of acute hypertension. You want to get down the pressure really quickly, but other than that, they're not going to be used very well for chronic dosing. And also for a lot of them, you end up seeing that tachyphylaxis. You guys remember what that means? Yeah, so like basically the drug kind of loses effectiveness over time, and where even if you increase the dose of the drug, you don't really get a lot of increase in effectiveness here. So again, because of that, they're kind of self-limiting, and so they're not great antihypertensive drugs. But we'll see some cases where we'll use these like more on the inpatient side for acute drops in blood pressure. So I'll see hydralazine here. Again, notice I'm not going to quiz you specifically on which side it's working on, but just know there's some differences here. Some are going to be more arterial, some are going to be more on the veins. It just depends on the drug you're dealing with. But again, more effects on the arterial side, the more reflex tachycardia and the more the sodium retention you're going to see. And that makes sense based on what we know about these reflex mechanisms, right? The name minoxidil ring a bell for anyone? Rogaine, yeah, so you can see it with Rogaine. We'll talk about hair growth here in just a minute here. So in clinical uses, we can use these for chronic hypertension, but they're typically not great for chronic dosing due to those reflex mechanisms. You typically use it as add-on drugs, again, third, fourth, maybe even fifth line drugs in this case. So hydralazine could be at one. Minoxidil occasionally. This is one I've not seen used clinically for actual treatment of chronic hypertension. Hydralazine, though, is a good one for kind of inpatient use. If you have someone who's having kind of acute high blood pressure, you can get this down pretty quickly with hydralazine. So it's kind of the same group as like labetalol, hydralazine, enalaprolat is on the ACE inhibitor side. All these are kind of quick-acting IV drugs that help get pressure down, which is nice. You can also, if you have someone who has an actual hypertensive crisis, which again, I'm not going to quiz you on the definition of that, but they have very severe hypertension, this is where you can use some IV infusions. You can have things like nitroprusside, and then there's also another two called diazoxide and phenoldipan. We'll talk about briefly. So hydralazine, this one is, again, we don't know the full mechanism for how it works. Some people feel that it has to do with increasing amounts of cyclic GMP. This helps to cause more vasodilation in the vascular smooth muscle, which can be good. Some people have, think it might help to enhance the effects of nitric oxide, or maybe affecting calcium. So again, it's one of those things where we're not really sure. We just know that it works. Sorry, this came out so small. But basically, if you're affecting, several, this is the vascular smooth muscle, affecting things like calcium inflow, affecting cyclic GMP. Again, this is going to have negative effects on causing smooth muscle contraction. So the more cyclic GMP you have, the more relaxation you have, essentially. Okay, so hydralazine is unique in the fact that it is acetylated in the liver. Do you guys remember we talked about acetylators before? Remember with isoniazid? We talked about that for tuberculosis. This is another thing where the drug is metabolized through this acetylation. You can have people have fast acetylators, you can have slow acetylators, and this is one is unique because of the side effect it causes. It causes lupus-like rash that can occur with slow acetylators. They build up levels of the drug. They hold on to more of the drug because they can't. The enzyme just doesn't work that well, and so you can end up seeing that rash. You can see this more likely with female Caucasians that have slow acetylation. Again, more long-term high dose use, you can see this. But again, that rash isn't very kind of very classic for that sort of thing. And again, due to the vasodilating effects, obviously headache, dizziness, flushing would all be expected with this kind of drug. This will be contraindicated, relatively speaking, with things like coronary artery disease. Again, someone has angina or someone's had a heart attack, dropping their blood pressure on the the vascular side is going to cause that increase in heart rate and cardiac output, and that can again put a strain on the heart from the oxygen demand side. So be careful with that. Again, one of the other unique things, again, anytime you turn a patient's stool or urine a different color, always let them know, because again, this can turn your stools black. If you think black tarry stools, what do you think of? Yeah, like a GI bleed. So you gotta be careful with that. So make sure that they know, hey, it might turn black. And you know anything else that can turn your stools black? Pepto-Bismol can do it. Iron's the other big one. Yep. Those are the big ones I know of, at least. Okay. Or if like you ate someone's dress socks, maybe that could probably do it too, but I wouldn't recommend doing that. But just you got to think through everything, you know. Okay, so we mentioned minoxidil. So this originally was designed as an antihypertensive, but all of a sudden they realized that abnormal hair growth was occurring as a side effect, so it kind of got relegated to topical use as Rogaine. Nowadays, you very occasionally see it being used as an antihypertensive in the oral form, but again, very, very rare. Have I mentioned my minoxidil story before? I had a older guy who was an alcoholic, couldn't find alcohol anywhere, didn't have any money, so he ended up going to the Walgreens, saw that, wow, Rogaine has like, you know, I don't remember what percentage alcohol by volume it is, but he said, I'm going to drink a whole bunch of this, and got really drunk off of minoxidil, and his blood pressure was like, I don't know, 50 over 20 or something like that. You know, and so we had him on every single vasopressor known to mankind in the hospital in the ICU for probably a week or so, because this stuff was so lipophilic, it just got all into his tissues and it was just leaching out for a week, it seemed like. He's on norepinephrine, epinephrine, phenylephrine, dopamine, every vasopressor out there just to keep his pressure high enough to where he even like be conscious. So it was pretty tough, but he, I mean, for better or for worse, he survived. Probably to do it again at a later date. Generally, stupidity begets stupidity, so you know he's probably not going to change his habits too much there. But I am not there to judge. I'm just there to make sure he survives. Okay. So minoxidil can actually be affecting potassium efflux here. So by affecting that, you can end up changing the how hyperpolarized or depolarized the cell is, and just basically makes it more difficult for the cell to contract. So again, you can see where it can cause that more on the arterial side, cause that vasodilation to occur. Again, pretty severe hemodynamic response, and cardiac output can double or triple in some cases. Very significant renin release. So again, poor antihypertensive, but you know, really good at dropping that pressure in the short term, but again, not good for chronic use. This can also affect arrhythmias if it was affecting potassium as well. So we'll talk more about that in the antiarrhythmic section, but just be aware of that interaction there. Okay, we mentioned hypertrichosis, which is a fancy name for hair growth. So be aware of that. If you're using it systemically, you can see that occur systemically and not just topically, or if you were to use it, like, say, on your head or wherever it happens to be, or if maybe if you want to like, put it just on your upper lip for Movember, whatever. But occasionally you can see if you had really, say, for instance, you were applying the Rogaine to like a large area, or say you put like an occlusive dressing, say, over the head. Imagine like put like a shower cap over it, and you know really kind of occluding it. You can end up seeing some cardiovascular effects, and those are maybe a little bit more susceptible to it. So it's not common, but you could see that with topical use. Okay. Another drug here called nitroprusside. This is kind of interesting because you'll notice that it is containing a certain molecule here. You know what that is? Cyanide, yes. This is actually a way we can give cyanide poisoning to our patients inadvertently, because this is a very good vasodilator because it helps to release nitric oxide, which we mentioned is important for causing the vascular smooth muscle to relax. But it also has 5 cyanide molecules bound to it. So that way, when if you have a lot of this being released, you know, as it gets metabolized, the liver is really responsible for getting rid of cyanide, and so you can have patients with poor liver dysfunction, or poor liver function, I should say. They can build up the cyanide levels, and you actually get toxic from that. So again, we'll give another drug to block those effects, which I won't mention here, but just be aware of that. But very good, especially if like in the ICU, if you have someone with really significant hypertension, you got to get their pressure down. This is a really good drug because it's short acting, and you can titrate it very easily via continuous infusion. Does anyone know what fruits contain cyanide? Yeah, apples. Anything else? Peaches. Yeah, so it's usually in the pits or the seeds. If you chew those up, you can actually see some cyanide being released. Okay, so I mentioned the cyanide toxicity. This is where you mentioned here the sodium thiosulfate is a drug you can actually use to counteract that. It helps the liver to detoxify a little bit better. Because again, your body produces a little bit of cyanide all the time, but the liver is really responsible for getting rid of that. Okay. And then if you had a patient with poor renal function, they couldn't get rid of one of the metabolites here, so they can actually have some issues where they have things like weakness, tinnitus, et cetera, occur. So just be aware, patients with poor renal and hepatic dysfunction, they're going to have a hard time with this nitroprusside. Not a good drug for them. Okay, we have phenoldiprem. This one's actually a dopamine agonist. So dopamine within the kidneys can actually cause some vasodilation to occur. It helps with renal blood flow. So you may see this one used occasionally, but good for kind of short-term IV infusions, maybe less than 48 hours to help kind of deal with an acute hypertensive issue while you get maybe some other meds on board. Nothing too much with this drug. Okay, so that's it for the agents for hypertension. This is the main thing I wanted to talk about here. So real quick, you guys mind if I go a few minutes over? Yeah. You don't have a choice, so it doesn't matter. Just kidding. So we have the JNC8. So this is most recent hypertension guidelines. Basically, you're going to find that the recommendations depend on what the indications are, what comorbidities the patients have. Generally, what you're going to find is a goal to have a blood pressure less than 140/90. This includes patients with diabetes, chronic kidney disease. They shoot for less than 140/90. What you typically find in the recommendations are, and again, this is going to be dependent on each patient, that generally you're going to find that the black population, with or without diabetes, they tend to do best on either a thiazide diuretic or a calcium channel blocker, right? So I might start out with like hydrochlorothiazide, or I might start out with, say, like an amlodipine, like a dihydropyridine. Those typically, the black population tends to respond best to that for whatever reason. Again, it has to do with the salt sensitivity and how much salt they tend to retain in the vasculature. They tend to respond best to that. For the non-black population, with or without diabetes, you can start with the thiazide, calcium channel blocker, ACE inhibitor, or an ARB. Typically what I see is that for those other patients, you will typically recommend like an ACE inhibitor, kind of first line, again, because that has a lot of good effects to help block left ventricular remodeling, kidney dysfunction, things like that. So again, kind of have your dealer's choice there. In general, chronic kidney disease patients should be on an ARB or an ACE inhibitor if they can tolerate it, right? Because it helps to prevent further progression to disease. Also, diabetic patients tend to recommend ACE inhibitors as well because it can help to prevent some of that nephropathy to occur over time. Make sense? Okay. Again, as far as monitoring goes, you try to maximize the dose of the drug that they're on currently. Usually check within a month or so and see how they're tolerating it. Again, you may change drugs due to ineffectiveness or toxicity, depending on kind of what's your patient is having go on. You can always add on a drug from a different class, though, right? So when you want to get some synergy there by working with different mechanisms. So I can add an ACE inhibitor, add on hydrochlorothiazide, or I could take say an ARB, add on amlodipine. There's lots of different combinations you can do. Obviously, you don't want to use an ARB and an ACE inhibitor at the same time. Why is that? The same pathway, essentially, right? So you kind of think of them as kind of synonymous mechanisms. We know there's a difference in the mechanisms, but again, they work on the same pathway, so it would make therapeutic sense to use both of these for those patients, right? So again, thiazide diuretic, ACE inhibitor, beta blocker, plus, say like a dihydropyridine. There's lots of different combinations out there. Every patient will respond a little bit differently, and they're gonna, it'll be a different, kind of preferred regimen for every patient. So, any questions on that? Thank you for bearing with me. You can listen to the video again, slow me down if you need to. I know it's a lot. Good thing the test is in 2 days. I'm going to. I'm working on a Kahoot right now. I'm going to post that up. I'm going to narrate the Kahoot and also give you a link so you can do it yourselves. You can kind of follow along if you like, and that way that will suffice for our review. So I apologize, we couldn't do it in class. If you have questions, email me sooner than later. Thank you.